Pues antes de Health First Colorado yo no llevaba a mis hijas al doctor porque al llevarlas a una clínica pues tiene que pagar uno mucho dinero. Es gratuito porque tengo que pagar un copago, depende, $5, $1, que no es nada, a $2,000. Me siento feliz de tener el Health First Colorado porque me siento segura así de llevar a mis hijas, porque muchas de las veces ahorita en el tiempo que estamos viviendo tan caro todo, créame que no las llevaba. Mejor con remeditos, pero el programa de Health First Colorado es súper excelente, yo lo recomiendo a las personas. Para mí, Health First Colorado me ha servido mucho para yo sentirme bien en mi salud también, porque si yo estoy mal, yo ya recurro a una clínica y ya no voy con esa preocupación de que yo diga, me va a llegar un bill caro. El Health First Colorado abarca todo. Me siento, como luego dicen, protegida por ese programa.
All right, are we ready for me to go, team?
Yep, let's do it.
Okay. Good morning, everyone. Thank you so much for joining us today. I'm Lieutenant Governor Diane Primavera, and I also have the privilege of serving as the director of the Office of Saving People Money on Healthcare. And I also lead the Office of eHealth Innovation. You know, since day one, the Polis Primavera administration has been committed to ensuring that all Coloradoans have access to high quality and affordable healthcare. We're pleased to have so many members of the healthcare community here today, and we hope that you'll find the sessions to be informative and engaging. I also believe there's a number of legislators with us today, so thank you for your leadership and incredible partnership, as well as for your public service. I know how hard you work. And thank you to the many thought leaders across the spectrum of the healthcare industry joining us today, including providers and advocates. I'd also like to welcome our Medicaid members, patients, families, and colleagues here in Colorado. We have a talented group of expert presenters today. You know, one of the top concerns of Colorado families continues to be the ever-rising cost of healthcare. From day one of this administration, lowering the cost of healthcare for Coloradoans has been a top priority. That's why we created the Office of Saving People Money on Healthcare. And both the Core 5 Health Cabinet and the All Roads Lead to Health Cabinet have been created. We've brought state agencies together, those that focus explicitly on healthcare, and those that provide a whole spectrum of services to Coloradoans, because we know that to truly address equity, access, quality, and affordability, everything we do must include innovative and collaborative ways to help Coloradoans truly thrive. We're also committed to naming and addressing the historical, systemic disparities that have kept too many people from accessing the care that they need. Equity is at the forefront of all of our affordability work. So next, I'll pass it to the dynamic and dedicated Kim Bimsteffer, Executive Director of Healthcare Policy and Financing, to go over the logistics for today and the agenda for the webinar. So Kim, do you want to walk us through the housekeeping details?
Absolutely. Thank you, Lieutenant Governor. It's always great to see you. Such an honor to have you leading our fabulous 5 and then the entirety of the Health Cabinet and the All Roads Cabinet, which is all the departments. What a privilege it is to work with you. And thank you so much for your passion. So before I walk us through logistics, I'm going to turn over to Johnny to talk us through a little bit of our Spanish interpretation and get some of the directions. Johnny, after you.
Sure. Thank you. Entonces vamos a tener interpretación simultánea para los que son de hispanohablantes, y si deseas escuchar el programa en español, puede entonces escoger en el pie de la página de Zoom el icono del globo y puede escoger entonces interpretación en español, Spanish en inglés, y puede escuchar todo el programa en español simultáneamente.
Gracias, Johnny. We appreciate that. And to all our Spanish listeners this morning, welcome. So good morning, Colorado. So nice to have you here. Welcome to the 2023 Health Cabinet Affordability Summit. So delightful to spend time with you. I'm Kim Bim, staff and executive director for the Department of Healthcare Policy and Financing. That's the department that oversees Medicaid and the Children's Health Insurance Program and provides coverage services to about 1.75 million Coloradans. We have a packed agenda today. Let's go to the next slide, please. 5 sessions, over 20 speakers, 2.5 hours. So we want to get through these logistics and then dive right in. So just to make sure you can use the Q&A feature on the toolbar just to answer any questions. We'll answer them at the end of the session, the end of the 2.5 hours today. There are over 1,000 registrants, so we probably won't get to all the questions that are presented. The presentations, links, and other materials are posted in the chat. Otherwise, the chat is closed. It's closed so that the panelists and the presenters can speak with each other and those who are coordinating our webinar and our Health Cabinet Summit today. You can leverage the pop-ups. That would be great. We love to hear from you and hear your opinions. The public service announcements between sessions, if you'd like a copy of those to use of your own accord, you can request those from Mark Williams, their email on the screen. And when we play those, we'll also post them again so you can see that. And for accessibility, ASL, audio-only Spanish interpretation, and closed captioning are provided today. So let's go to the next slide, please, and dive right in. So here is what we're going to cover today. An exciting day. We're going to start with a session on rural hospital supports. Then we'll move to prescription drug affordability, hospital affordability, report findings, new tools, and some policies in process. We'll have a session on keeping Coloradans covered, really important about the end of the public health emergency. We'll close the day with last session that's about value-based payments. We'll open up for questions. We'll use that Q&A feature that I just referenced, and the Lieutenant Governor will bring this Health Cabinet Summit to a close. So let's go to the next slide, please. And so our dream team here on rural hospitals, Nancy Dolson is our HCPF Special Financing Division Director. She's going to moderate this session. Ben Anderson, we're so delighted to have Ben from CHA, who oversees the rural hospitals and providers and that relationship between CHA and the providers. Ken Stansberry's here. He's the board director this year of CHA. He's also the CEO of Lincoln Hospital. Michelle Mills is the CEO of our Colorado Rural Health Center. And Stephanie Puglisi is the director of the Colorado Office of eHealth Innovation, which reports into our Lieutenant Governor. So with that, Nancy, I will turn it over to you.
Thank you so much, Kim. Good morning, everyone. So happy to be with you here today. I am Nancy Dolson, our Special Financing Division Director at HCPF. I oversee the Chase Hospital Provider Fee, our hospital transparency work, Colorado Indigent Care Program, school health programs, our senior dental program, and more. And I'm excited to be kicking off this first session on rural hospitals, including some opening slides and then moderating a lively discussion with our expert panel. So let's dive right in. As you may know, more than 12% of Coloradans live in rural areas, and about 30% of those individuals qualify for Health First Colorado. So investing in rural health care and our rural providers has been and will continue to be critical to HCPF, to the state, to our providers, and to our rural communities. Doing so helps us improve affordability, access, quality, while closing disparities. It also helps improve the health of rural Coloradans while boosting our rural economies. I am excited to share with you, first of all, some of the highlights of our transparency work and then to moderate our expert panel today. Next slide, already moved there, thank you. Oh, please go back, my apologies. Thank you. So this slide illustrates the dramatic difference in the percentage of rural expenses that go to covering overhead versus going to covering patient care. You can see that on average, more than 38% of each rural hospital dollar goes to administration and overhead, while about 61.5% goes to patient care. This compares to 26.3% for large hospitals' administration costs and 73.8% going to care. Of course, we all want as much money as possible to go to patient care as possible, so this represents an efficiency opportunity. Now, next slide, please. Thank you so much. Here on this slide, we look at a distinction between rural and urban hospitals' days cash on hand, sometimes called reserves or rainy day reserves. The 2019 rural hospitals had median days cash on hand of 123 days. Then in 2020, they had 207 days median days cash on hand, and in 2021, 215. The driver behind the 2020 increase is the federal stimulus dollars paid to hospitals to help them through the COVID pandemic. Clearly, we also use these sorts of dashboards to monitor and propel sustainability of our rural hospitals. Okay, next slide, please. I'd like to talk to you about what the state is doing around rural hospital transformation. The state has prioritized rural hospital investment in a variety of ways, particularly around transformation and innovative investments, access to telemedicine, broadband, and more. Our hospital transformation program is the state's first major effort to significantly redirect hospital supplemental payments toward delivery model transformation to the betterment of all Coloradans, regardless of payer or coverage type. And a critical component of that HTP is its Rural Support Fund, which helps prepare our critical access and other rural hospitals to meet the emerging needs of communities they serve and to administer emerging payment methodologies. That Rural Support Fund will pay $60 million over 5 years, and half of that has been paid to date. The Office of eHealth Innovation is investing $17.4 million to connect rural providers to health information exchanges, which helps providers exchange information and improve patient care and outcomes. And additionally, the governor's budget proposed $10 million in stimulus funding to support rural hospital access and affordability initiatives. That was passed by the legislature and is being managed by HCPF and an advisory committee. And yesterday, we were pleased to release the application for rural hospitals to apply for these rural provider access and affordability stimulus grants. Let's go to the next slide, please. So with that background, I would like to let us hear from our distinguished panel. I see we've got folks coming on camera. Wonderful. As I ask each of you questions, I would ask that you please start first by introducing yourself. And I'm going to turn first to Ben. Can you tell us about the Colorado Hospital Association's mantra in supporting rural healthcare and hospitals?
Sure. Thank you, Nancy. My name is Benjamin Anderson. I'm Vice President for Rural Health and Hospitals with the Colorado Hospital Association and a longtime hospital CEO by background. And I've been with CHA for 4 years. CHA believes that to accurately assess the well-being of rural healthcare delivery and the healthcare delivery safety net, we got to start by asking the right questions. So we have an ongoing process whereby we're polling, we're asking, we're engaging rural healthcare delivery systems around the state to make sure we understand the challenges and the assets that they have to meet the needs of rural people. So classically, we'll say that just like in medicine, if we have the inaccurate diagnosis, any intervention that we bring forward is either waste or harmful. And so we're committed to continuing to ensure that we have that, that accurate assessment of what's going on. We've spent the last 4 or 5 months developing a strategy that we're actually launching later this morning at our CHA annual Rural Health and Hospitals Conference. And it's really a 3-part strategy. And the first part is rural advocacy, making sure that every policy that's brought forward, every legislative bill, but as CHA engages with it, that we make sure that it has a rural lens on it, that we're making sure that it balances the needs of all the hospitals around the state, and expressly reflects the strong rural voice and priorities as we look at those bills. And then we leverage that process to advocate for the long-term financial viability of our healthcare delivery system. So the first is really rural advocacy. The second is what we would call collaborative capacity building. And we understand that policy is important, but if we don't have the capacities locally to make good use of good policy, then we really can't get where we need to go. And so we have rapid response services. If a rural hospital needs access to support from, for example, HCPF or the Healthcare Policy and Finance Department, we've engaged Kim and the group at the state to help rural hospitals if they have an individual need, or it could be that they need access or support with physician recruitment. We're engaging our partners at the Rural Health Center to help with primary care access, things like that. Whatever it is that they need to ensure that they remain strong, we're engaging them in that way. And then we're also engaging their boards. So we often say that the condition of the board is also, it reflects the condition of the healthcare delivery system, and a highly functional and engaged board is essential. So we're doing board training around the state, making sure that the boards have what they need to function well, building the capacities within those areas. And then lastly, transformational leadership. So we know that any healthcare delivery system that's going to really effectively meet the needs of communities is going to have effective transformational leaders at the forefront of that healthcare delivery system. And it's so important that those leaders reflect the communities that they're serving. So we're working on the development of a diverse group of leaders that can lead healthcare delivery systems, starting with pipeline efforts to bring people up from the frontline level into mid-level management, and from mid-level management to senior leadership and even governance, making sure the governance teams reflects the communities that we're serving. And so we're really looking at a holistic view around strengthening our rural hospitals that starts by asking the questions that are most relevant to rural people. So Nancy, with that, I'll turn it back over to you.
Great. Thank you so much, Ben, for your passion and partnership. Now to Michelle. Can you talk more about rural hospital finances and how we help ensure rural community members can access the health services they need by leveraging the $10 million ARPA affordability and access monies?
Yeah, thanks, Nancy. Hi, everyone. I'm Michelle Mills, and I'm the CEO at the Colorado Rural Health Center. We are the state office of rural health and Rural Health Association in Colorado. So hospital finances, they are better, I will say, than they were pre-COVID. We have currently 16 rural hospitals of the 43 that are operating in the red right now, which is down from the 22 that existed last year. But in large part, because of what you said, Nancy, earlier, that's due to COVID funding that came in, and we definitely understand that there's this tsunami that is coming when COVID funds end. Also would like to point out that about 75% of the funding for a rural hospital comes from their outpatient clinic, and they have an average daily census inpatient of 1 to 3 patients. So really large part is coming from that outpatient part. Really fortunate for HCPF and our state to really recognize that rural is different, and that, you know, we serve a very diverse population in terms of older, sicker, poorer patients in our rural communities. Very thankful that the $10 million bill passed last year, and so that was Senate Bill 22-200. That was called the Rural Provider Access and Affordability Stimulus Grant Program. And as Nancy mentioned, that was released yesterday. So we're very excited about it. This is going to give the opportunity for rural hospitals to apply for up to $650,000 in funding that can be used over a couple of years period of time. Also, they can use that funding for health information technology. A lot of our rural communities struggle with being able to upgrade and afford new electronic medical records. They're very, very expensive, and just like your phone, you know, those things don't last forever. You have to upgrade them. So I think that's going to be very helpful to folks. Also expanding access to care in terms of replacement of outdated equipment. It could be used for that. Along with other facility upgrades that really bring that access to care more to light. There was an advisory panel that was put together. Very proud that there were for rural community members in terms of 2 rural hospitals and 2 frontier hospitals, and then 1 consumer along with myself. And I had the ability to chair that committee. So really excited to see proposals when they come in, and those will be due soon, with money going out this summer. And that's really great opportunity for us. So thank you, Nancy.
Excellent. Thank you, Michelle. And thank you so much for chairing that advisory committee. It was really quite a pleasure to work with you and the other members. Great. Turning now to Kevin. Can you please talk a little bit about strategic partnerships and approaches that could help improve access and outcomes in rural communities?
Yeah, Nancy, thank you very much for having me today. I want to first give a shout out to my partners on the panel. In the spirit of partnership, we enjoy our relationship with HCPF. Ben, of course, we have a very close relationship through CHA. Very pleased to be working with Michelle on the policy and legislative committee through CRHC, and then Stephanie is our great leader for the Office of eHealth Innovation. So that's the kind of collaboration that works best in rural. I want to start out by pointing out the fact that you raised the issue of higher administrative costs as a percentage of overall expenses in rural. It shouldn't be a surprise to anybody that our costs incrementally tend to be higher than those in the urbans. We're typically independent hospitals. We don't have the bargaining power necessarily to negotiate with the drug companies or with medical equipment companies. And so what we're working to do is to try to collaborate together to find ways, innovative ways that we can look to improve quality, increase access, and bring the cost of healthcare down in rural settings. While our cost, again, comparatively speaking, as a percentage of our overall cost may be higher for administrative, I would submit that our overall costs per patient discharge tend to be lower. There's a lot that goes into that, but we're very aware of those things and working really hard to find ways to reduce those costs. I would also say, again, back to Michelle's point about the COVID money, that was very generous, and we were pleased to have been supported by the federal and the state government during that very traumatic time. But that was a one-time contribution to take care of an emergent need. And I'm very much an advocate to look for ways where we can have the long-term discussion to deal with the key 4 issues that those of us in rural and frontier health are faced with. One is we want to find ways to make sure we're delivering those essential services in our community. Secondly, we've got to have the workforce to do that. How do we create those pipelines out of rural junior and senior high schools and turn those folks into healthcare professionals? Out of all of that, we need to figure out a way to have a sustainable margin. We spend a lot of time on standby waiting for services that are needed to be delivered. For example, an emergency department. And that raises, again, our administrative costs because there's a fixed staffing that you have to maintain. And so we want to figure out a way to get reimbursement to a level that covers those costs. And then finally, access to capital. Again, we're very grateful for the $10 million grant. As everyone on this panel knows, the need is great in rural. My hospital, for example, was built right after World War II by volunteers who came back from the war, and they contributed their time, their money, their materials, and they built the hospital. That's the same building we're operating in today. It's been expanded a bit, but the essential building remains the same because of our low margins, and that's not untypical in rural areas. We've not been able to build up reserves to make those investments to keep pace with what's going on in technology. And from an equity standpoint, and again, Michelle and Ben both pointed out, we deal with sicker, older, poorer patients typically. We want to make sure that we're delivering the care that's needed. So I'll stop there, and thank you for the opportunity to offer a few comments. Thank you.
Yeah, absolutely, Kevin. Thank you so much. So good to be here with you this morning. And then I'd like to turn now to Stephanie. Can you share the work of the Office of eHealth Innovation with rural communities, what's been accomplished, and tell us what's on the horizon?
Yes, thank you, Nancy, and good morning, everyone. My name is Stephanie Puglisi. I'm the director of the Colorado Office of eHealth Innovation, and we are located in Lieutenant Governor Diane Primavera's office. So I'll dive right in. We are on a breakneck speed here today. So a crucial initiative supported by the Office of eHealth Innovation, or OHI, and the eHealth Commission, and one of our esteemed members, Kevin Stansberry, is here with us today too. So shout out to Kevin, is rural connectivity. So we established the Rural Connectivity Program to address gaps in the State Health Information Exchange Network by providing affordable and effective technical connectivity options for the rural critical access hospitals and certified rural health clinics. Health Information Exchange, or HIE, we love acronyms around here, enables health providers to view and share X-rays, MRIs, test results, and clinical information with one another in real time. So instead of you having to carry perhaps a CD or some other record between providers, the goal of Health Information Exchange is for that to be seamless and not to be a burden on the patient. This access avoids duplication of imaging and tests between doctors, which both saves money on healthcare and results in better care. Sorry, my computer had a little whoops there. For the baseline survey assessment and metrics in rural Colorado conducted in 2019, OHI determined that all 60 independent rural clinics and 49 of 84 total rural safety net facilities, and these are again the critical access hospitals and certified rural health centers, were not connected to the Health Information Exchange Network. And they also lacked the technical workforce and the access to analytics due to affordability of these solutions, tight operating budgets, and workforce capacity. So really showing what everyone else has said here today too, and the technology is reflective of these tight margins in the rural areas as well. So the good news is, since receiving state and federally matched funding in 2021, we've connected 98% of critical access hospitals and certified rural health clinics to the HIE network and analytic infrastructure. So we're making quick and effective progress. And last year, legislators approved additional funding for a one-time investment to onboard rural independent providers. So this includes primary care, behavioral health, and social programs to the state's Health Information Exchange Network based on demonstrated need. We greatly appreciate the enthusiastic support of the Joint Technology Committee, Joint Budget Committee, and Colorado Legislature in approving these funds and projects. In the initial infusion of technical support and expertise to upgrade, construct a comprehensive workflow, and provide necessary training to providers and staff will build the foundation for ongoing digital transformation, which will reduce the need for technical staff over time. We will be working with our community and technical partners to kick off this work later this year. We've also continued talking with rural healthcare leaders to understand rural-specific challenges that could benefit from shared solutions. We're working with our eHealth commissioners, including Kevin, as well as shout out to Michelle, who's a former eHealth commissioner and our former chair, toward vetting possible solutions to offer rural providers in areas including electronic health record systems, cybersecurity, and reporting needs. And then another shared system and exciting opportunity currently in the works and on the horizon at the state is our Social Health Information Exchange, or SHIE, SHE. The vision of this effort is to enable data from state, community, and health systems to be available to the right providers at the right time in support of coordinated whole person care across the physical, social, and behavioral health needs. We recognize there are many innovative efforts to address this already underway throughout the state, including both my fellow state agencies as well as in communities. And this is why we're focused on a two-pronged approach, both supporting and elevating local community efforts, as well as developing a statewide unifying technology solution. In this way, we aim to leverage current systems and processes, as well as the lessons already learned from their development and implementation. We are currently reviewing proposals for the solution and hope to have a contract in place by July 1st of this year. This will enable our healthcare providers to truly focus on patient care, reduce time spent on paperwork, and get Coloradans referred to the support they most need. This is a first in the nation system that will incorporate the social determinants of health with physical and mental health. Access to food, transportation, and other social services and supports is key to good health. With safely shared and available data, health providers can more successfully provide whole person care to all Coloradans. And with that, I'll turn it back to you, Nancy.
Excellent. Thank you so much, Stephanie. Really exciting to hear about the work going on at Ojai and what's getting ready to come forward. Just want to take a moment and just note a quick note of gratitude to my panelists here for joining me this morning. Ben, Michelle, Kevin, and Stephanie, great to see you all. And with this, I'll turn it back over to Executive Director Kim Bimsteffer.
Thank you, Nancy, and thank you, Dream Team in rural Colorado. I really do mean that from my heart. There's so much going on, and we couldn't get it all done without extraordinary partnerships and collaboration and a united effort to just tackle what keeps coming at you. And I really, truly appreciate the passion to serve that each one of you brings. You bring your gifts and blessings, and then you just drive it through with passion, and it's really quite spectacular. So thank you so much. So we're going to drive now to our next topic, which is prescription drug affordability. Now, as you may know, Healthcare Policy and Financing released a report first in 2019, and then we updated it in January 2021, and it provided the drivers of rising prescription drug costs and solutions or alternatives to address them. We'll probably put that in the chat shortly, so you can pull that down if you like. And so we've used that in order to drive a lot of the solutions that we've rolled out as a state. So let's go to the next slide, please. So that had federal and state solutions. And as you all know, the prescription drugs, we spend so much more in this nation than we do in other countries. We also have about 10% of Coloradans that are unable to fill a drug because of the cost in 2021. That's based on a recent survey done. And prescription drugs are the leading driver of overall rising healthcare costs. And that's largely often due to the increasing amount of all of our budgets that high-cost drugs consume. So less than 2% of drugs that are prescribed by physicians here in Colorado and across the country are so expensive, they're consuming more than 50% of budgets. And whether you're talking about commercial coverage and employer HCPF and Medicaid, that is the lead driver. So this panel is going to address many of the solutions going on that were outlined in that report, and the solutions are being driven by a variety of departments and individuals. Let's go to the next slide, please. And so again, we have a really distinguished panel. Lila Cummings is on the panel, coming from DOI, Prescription Drug Affordability Board, or PDAB director, but she's also going to talk not just about PDAB, she's going to talk about, give you an update on our rebate legislation that went in last year. Lauren from HCPF is manager of our drug importation program, so she's going to talk about that. Tom Leahy's going to talk about both. He directs our pharmacy office, which has a $1.1 billion spend, one of the highest in the state for prescription drugs. He's going to talk about our prescriber tool as well as value-based payments. And we're honored to have Dr. Jerry Anderson, who's a PhD from Johns Hopkins. And he might be a familiar face to you because he's often testifying as an expert before Congress. So with that, let's get to the next slide, and I'm going to turn it over to Lila. Really great to see you. Thank you so much for joining.
Good morning. Thank you so much, Executive Director Bimsteffer and Lieutenant Governor Primavera. So I am Lila Cummings. I am the Prescription Drug Affordability Director within the Department of Regulatory Agencies at the Division of Insurance. And we can go to the next slide. So I support the work of a new program within the Division of Insurance. And as Executive Director Bimsteffer said, we affectionately refer to it as PDAP, the Prescription Drug Affordability Board. So that is a 5-member board, and you see the 5 members here up on the screen. And they have a number of duties, and we'll dive into the weeds a little bit on what they do in some of the areas. So they have the authority to and the responsibility to perform affordability reviews of prescription drugs. Then for drugs that they deem unaffordable to Coloradans, they may establish upper payment limits on prescription drugs. And they also have responsibilities to collect and evaluate data on prescription drugs, as well as make policy recommendations to the General Assembly. Then, and I won't go into every member here, but there is a very robust and very qualified advisory council of 15 members that really represents every perspective in the prescription drug supply chain and arena. So you've got folks from the healthcare consumer perspective, as well as employer perspective, carrier perspective, manufacturer perspective, all the way to pharmacist and wholesaler. And this advisory council, their duties are to provide input to the board regarding the affordability of prescription drugs, as well as specific input when the board is selecting drugs for an affordability review. And I scrolled through the attendees today, and I know we have a number of board members and advisory council members here today. So they're very familiar with the kind of whole world of healthcare affordability. We can go to the next slide. So one of the things that we'll talk about a little bit is affordability reviews. So the board has a responsibility to conduct affordability reviews for prescription drugs, and it's a multi-stage process. So the board starts by identifying prescription drugs that might be unaffordable to Coloradans. So they will go through and look at the lists of qualifying drugs that are outlined in statutory criteria as prescription drugs that might be unaffordable to Coloradans. And then after they approve this list of prescription drugs that are identified, they then go on to a selection stage where they prioritize the different selection criteria. What are the different affordability goals that the board has in a year? And what might they want to select, which drugs might they want to select for a full affordability review? Then they can conduct a full affordability review, which is a real academic exercise, but as well as a stakeholder exercise in talking to providers and consumers on, for the specific drug, what are the affordability challenges that Coloradans face? And then at the end of the day, after doing all of those things, the board may determine that a prescription drug is unaffordable. If the board determines that a prescription drug is unaffordable, the board may choose to establish an upper payment limit for that prescription drug, and that is a limit on what consumers and providers and carriers can pay for that drug in the state of Colorado. I will say that the law was passed in 2021, and the board has spent a year in rulemaking and kind of getting the guardrails of its program up and rule. And this first year is kind of when the board is doing its work and anticipates doing between 5 and 10 prescription drugs in this first year for affordability reviews. And we can go to the next slide. So timeline. So the board is going to select drugs for an affordability review this spring, conduct affordability reviews and determine if a drug is unaffordable. The goal is for the summer and fall, with the anticipated dates for the board potentially selecting drugs for an upper payment limit or UPL and establishing an upper payment limit this winter. And then that would result in an effective date of an upper payment limit sometime in summer or fall of 2024. So that is at the quickest level, the overview of the work of the Prescription Drug Affordability Board. And we can go to the next slide. So as Executive Director Bimsteffer said, the Division of Insurance is also in charge of a rebate pass-through bill and study. And this is not my expertise, but I'm very close with the colleagues who run this. And so they've given me authorization to kind of give an overview here. So rebates on brand name drugs average 20% of the drug price. And that's according to a 2021 report from the All Payer Claims Database. So there was a bill passed last year, House Bill 221370, which requires pharmacy benefit managers and carriers to pass rebates through and not retain them to consumers and employers on insured policies effective January 1st of 2024. This bill also includes opt-in language, enabling self-insured employer plans to leverage these savings if they choose to. So the Division of Insurance is in the process of studying rebates in the individual market and evaluating how those rebates may be applied to reduce out-of-pocket costs at point of sale or in prescription drug tiers. And this report is going to be published this summer.
Thank you so much, Lila. That was spectacular. And, you know, both of those areas of focus are just really instrumental to curbing this #1 driver of rising healthcare costs, which is prescription drugs. And you think about PDAB as a lot of the higher cost drugs, and you think about this rebate pass, there's a lot of just common drugs that are used every day. Rebates are paid on brand name drugs. If that's about 20% savings, we talk about and the PDAB again is at less than 2% are driving the lion's share of rising healthcare costs. So important. And then Lauren's going to talk about importation at the end. Dr. Jerry Anderson is going to talk about spread pricing, which has about the same as much as about 19% to the smaller employers. So these are big strategies that provide big takeaways. So thank you again, Lila. And over to you, Lauren, to talk about the good work on importation.
Thanks, Kim. Good morning, everyone. My name is Lauren Reevely. I'm the Drug Importation Program Manager for the state of Colorado, and I'm really happy to be here this morning to talk a little bit about the importation program and the savings the program will bring to the commercial market in Colorado to the benefit of consumers and employers. Next slide. My team has been implementing the state's drug importation program to bring savings on commonly used medications to the commercial market since late 2019. Since then, the program has seen much progress: an issuance of a final federal rule putting the regulatory framework in place, the successful procurement of all supply chain partners, and Colorado's submission of a Section 804 importation program application, or as we call it, a SIP, to the FDA for review and approval. So you'll see on this slide a process map which shows our supply chain. So our supply chain starts with FDA-approved manufacturers. Our foreign seller, Adira Medica, will purchase products directly from the manufacturer and ready them for exportation to the United States. Once across the border, our importer will take over, and that is Premier Pharmaceuticals. They will ensure that the products are intact, have not been tampered with, and are stored in a secure area of their warehouse while awaiting further processing. The importer will arrange for testing of imported products, and once the test results are approved by the FDA, the products will be relabeled and distributed to participating Colorado pharmacies. Our safe and secure supply chain ensures that Coloradans will receive the medications that they rely on. As I said, we submitted our application to the FDA this past winter in December. We are awaiting FDA approval of that application, but we'll be collaborating with our federal partners over the coming months to ensure a speedy approval. And we are targeting Q1 of 2024 to begin importing. Next slide, please. So as part of our SIP, we conducted an analysis of high cost and highly utilized drugs using Colorado-specific data from the Colorado All-Payer Claims database. Across the 112 drugs that we included in our analysis, we found an average of 65% savings across all of these drugs, which amounts to about $53 to $88 million in annual savings per year. And this number is dependent on market adoption. And we used a fairly conservative estimate of 15 to 25% to estimate that market adoption. It's important to note that our drug list is 80% brand and 20% generic. And we've generally focused on brands, but we have found that there are opportunities in the generic space, and generic manufacturers may prove to be early adopters and partners for our program. Right now, our drug list is aspirational, and this is due to the way that contracts between manufacturers and wholesalers in Canada are structured. And so because of that, we must negotiate directly with drug manufacturers to secure drug supply for our program, and that process is underway. Next slide. And so finally, we see importation as an opportunity. Colorado's program creates a new marketplace for prescription drugs, which will offer lower cost medication with pricing transparency. We know that our most vital partners in making this program a reality will be manufacturers, health plans, and PBMs. And we've begun negotiating directly with manufacturers in Canada to ensure drug supply for this program. And we'll be working with Colorado health plans and PBMs to ensure that Coloradans with insurance can access imported products. We see promise for the program to benefit all parties. Manufacturers will be able to increase access to a new marketplace, providing greater access to their products. Health plans, pharmacies, and their customers will see more affordable pricing. We appreciate our industry partners at every step of this program and are excited to truly realize its potential and save Coloradans and our employers money on healthcare in the coming months. And I'll kick it back to Kim. Thank you.
So thank you, Lauren, and thank you for your incredible work in leading this importation process. There's no playbook, and you're building it from scratch and leading the nation, and we really appreciate everything that you do. And everybody on the phone or on this call that have been partnering with Lauren and the importation team, thank you so much for your leadership. Now we're going to turn it over to Tom Leahy. Tom is the office director for our pharmacy department here in at HCPF. So Tom, over to you.
Thanks, Kim. Good morning, everyone. As Kim said, I'm the director of our pharmacy office here at HCPF, and I'm going to talk about the prescriber tool and value-based contracts this morning. Next slide, please. All right, so the prescriber tool is really a collection of features that prescribers can access through HR systems. So in phase 1, we implemented the OPSAFE platform, which went live in January 2021. This module helps prescribers prevent the misuse, abuse, and overprescribing of opioids, benzodiazepines, and other controlled drugs. To date, almost 5,300 licenses have been allocated to Medicaid prescribers. And after the first 12 months of this program, the average dosage per opioid prescription was reduced by about 16%, which is truly outstanding. In phase 2, we implemented the affordability module through a soft launch in June 2021. This module shares real-time cost information with prescribers. It supports the transmission of electronic prescriptions directly to pharmacies. It helps docs understand at the time of prescribing which drugs need a prior authorization. And it supports electronic prior authorization requests, so docs can receive par determinations within minutes, if not seconds. So the affordability module helps improve service to members, makes it easier for providers to care for members, and it helps providers be part of the affordability solution. In 2022, this module helped save over $6 million gross of rebates. And then lastly, phase 3 of the prescriber tool is in the procurement stage of development. Eventually, it's going to help our docs and others providing supports to Medicaid members to prescribe programs, not just pills. So for example, WIC to pregnant members, SNAP to those who are food insecure, prenatal support programs to pregnant people, or diabetes management programs to those whose A1C metrics are not in line. Next slide, please. So the prescriber tool is currently accessible through 23 HR systems, including highly used systems like Epic, Cerner, and Athena. And finally, I just want to say thanks to all those providers who have participated in the uptake and adoption of this tool. Next slide, please. All right, so let's talk about value-based contracts. As you can see on this slide, just under 2% of drugs are so expensive, they're driving more than 50% of prescription drug costs. And that's for both Medicaid and commercial health plans. And those stats don't take into account the specialty drugs, which have recently come to market with really high prices. And you can see some examples there on the right side of the slide. So VBCs enable us to better hold manufacturers financially accountable to the clinical outcomes demonstrated by real-world evidence and results, which is especially important given these high prices. Through the contracts with manufacturers, we're able to tie the ultimate drug costs to our members' clinical outcomes. We currently have 3 contracts in place, and with more to come. Next slide, please. And back to you, Kim.
Thank you, Tom, as always. And I want to underscore a special shout out to Centurion University, or UC Health, who picked on and really worked hard with Epic to make some major changes that we needed to get the biggest EHR system in the state up and running. I also want to shout out that it would be inappropriate for us to ask prescribers and docs to be part of the affordability solution without giving them the tools to do so. And the prescriber tool, starting with OPSAFE, moving to affordability and giving them options that they could see the different costs. When those docs adopt OPSAFE, when they adopt the prescriber tool, it's not just for Medicaid, they can use it for commercial too. All of the major carriers except for Kaiser has their own unique tool, which is where we learned about why we should, as a state, should have a prescriber tool, because we learned from Kaiser. So shout out to Kaiser too. This tool actually helps all Coloradans be able to better afford their drugs and commercial and Medicaid. So well done, and thank you, Tom, for your leadership. Okay, now we're going to turn it over to Dr. Jerry Anderson. He's going to talk about spread pricing. And again, if you've seen him, you're probably familiar because he's testifying before Congress. So we'll turn it over to you. Jerry, good to see you.
Well, thank you. So I'm a professor at Johns Hopkins, and as a professor, we write a lot of papers and treat a lot of students, but we essentially need to figure out what's going on in the world. So I spend a lot of time in Congress and at the White House talking about issues, but where I really learned the most is places like Colorado, because the states are the place where all of the innovation is occurring. It's not occurring in Washington. It's occurring in places like Colorado, and people like Kim are the ones that are driving the innovation. So I want to talk about things that I've learned from Colorado. Next slide. So as Kim said, next slide, yeah. As Kim said, a small number of drugs are responsible for a large percentage of the cost. And these tend to be gene and cell therapies. These are great new innovations, but exceedingly expensive. And so what I've been working with is CMMI to develop a program to assist states to try to do this. So Colorado is already using value-based payments to do it. Tom just talked about this. What we're essentially saying is we could see if we can do this at a national level, and Colorado is taking the lead in helping the federal government do this. We're also trying to figure out if we can do a subscription model or a promoting access model, which will help states purchase unlimited amounts of the drug at a single price. We worked with Louisiana a couple of years ago on hepatitis C drugs, and now we want to see if we can do it for some of these very expensive drugs. And so you can take a look at the bottom and what CMS is doing in this particular area, and there's a lot more work to be done with Colorado. Next slide. Kim also asked me to talk about spread pricing. And this is just one of many things that people are doing related to PBMs. And what spread pricing is when a pharmacy is paid one price for a drug by the PBM, and then they turn around and they charge the employer a higher price for that same drug. So if the drug, for example, is the pharmacy is paid $75 by the PBM, the carrier then gets charged, or the insurer, $85, generating a $10 markup. Very nice, but the PBM doesn't have any role in the supply chain, so they're marking up drugs. They're doing spread pricing because they can. Who's being harmed by this? Well, it's employers and patients. Health coverage is important. We all get some kind of raise, but if healthcare costs were increasing slower, well, hopefully we would get a larger raise. So employer costs go up, threat to employees, their raises, and out-of-pocket costs. Next slide. It's important to look at what PBMs do and don't do. They administer the drug benefits for employers. They've been doing this for about 40 years. They negotiate drug prices. They create formularies. What they don't do is develop drugs. They don't manufacture drugs. They don't take the drugs from the manufacturer to the pharmacy. They don't dispense drugs. What I think of them as the classic middlemen. And there's really only 3 of them that control 80% of the market. And they are all connected somehow to somebody else. So Cigna is part of Express Scripts, CVS and Aetna are together, Optum is part of United Healthcare. So they're all interconnected with other parts of the healthcare system. We don't know exactly how much they make right now. We did a study that we published showing that they made $12 billion in 2016. We think it's more, but we don't have the data at this time. Next slide. So what's going on? Well, essentially, there's a federal rule mandating health reporting on healthcare and drug spending related to spread pricing. The Federal Trade Commission is taking a look at the largest PBMs to provide information. And there is bipartisan legislation to do transparent pricing and eliminate spread pricing. Exactly the things that Colorado is already doing, but it's going to be much more effective is done at a federal level. So we're just learning from what Kim and the state of Colorado is doing in these activities. Thank you very much. I think is there another slide? Yeah, I'm sorry. One more thing. What's going on at the state level? So there are 12 states that are passing legislation. Colorado's not the only one, but is essentially one of the leading ones. They're essentially involved in analyzing claims data on spread pricing. There's in court suits, which have shown almost $1 billion in settlement from just one company. So this is an issue that's around, and we're dealing with it in a variety of areas. But again, Colorado is taking the lead on this. Thank you.
Okay. Thank you very much there, Jerry. We appreciate that. So again, two big things going on. The rebate pass through would be effective on January 1. Spread pricing could be effective on 2025, and getting both of those in their current state would affect insured cases. We would want employers opting in. So both of those are very exciting. Importation is could really be a game changer, bringing 61% savings. And the PDAB is just exceptional. And Jerry didn't say it, but he's actually a member of the Maryland PDAB, a very small board, just like ours. So I want to really say thank you to Lila and to Lauren and to Tom and to Jerry for leadership and helping us drive these wonderful strategies forward. And appreciate the poll that everybody took. We'll share that afterwards as well. Let's go to the next slide, please. So now that we've talked about prescription drug affordability and the solutions and provided some updates on where we are as a state, I also want to turn us now over to the next driver of rising healthcare costs, and that's hospital. So we've done a lot of reports as a state, and this session will do a good job of sort of talking about some of those reports, giving us some insights and driving us to the next level of conversation. But before we jump into that, let's go to the next slide, please. You know, our frontline workers, our hospital leaders, docs, what you've been through in the last few years and the exceptional service that you've provided to Coloradans, exceptional care, the results of where we are as a state compared to other states, wonderful collaboration between hospital leadership, CEOs, CMOs, chief medical officers, Governor Polis, Lieutenant Governor Primavera, the state agencies has really been unsurpassed. I want to just do a special shout out with sincere gratitude to our frontline workers. This has been an absolutely unprecedented time. We truly appreciate what you've been through and the contributions that you've made over the last 3 years. And just a special shout out as a mama bear of Medicaid and the Children's Health Insurance Program for your services to 1.75 million Medicaid and CHIP eligible Coloradans as well. The way that you stepped up with a massive effort, given COVID, given all of its aspect, again, without a playbook, has just been unprecedented, exemplary, and just illustrates the dedication of our hospitals, our docs, and our frontline workers, our nurses, and all frontline workers. We want to thank you on behalf of the administration, on behalf of the department, on behalf of all the departments under the administration. Today, we want to thank our workers for your tremendous support for our communities. Now, with that, let's go to the next slide. And let's talk about, again, a distinguished panel. We have Marilyn Bartlett, who has many initials after her name, CPA, CMA, CFM, Senior Policy Fellow for the Center for Health System Costs at the National Academy for State Health Plans, what you might know as NASHP. Nancy Dolan, once again, our HCPF Finance Office Special Financing Division Director, and we're honored to have with us today CEO. And everybody knows Donalyn. If you don't know Donalyn, you may have registered for the wrong seminar this morning. So with that, I want to turn this over to Marilyn. Really good to see you, and thank you so much for moderating this session, Marilyn. Great to have you here.
Well, thank you, Kim. Thanks for inviting me. I'm really pleased to work with this group and learn everything Colorado's doing. Next slide, please. We want to take a look at what other states are doing around the community benefit aspect. We see a lot of focus on transparency right now from a national perspective, that hospitals are required to report detailed costs. We have that in Maryland. We have some ongoing work. We're working with legislatures in Indianapolis, North Carolina, and Montana on a template to flush out a little more detail. We also see hospitals must make the community health needs assessment and implementation strategies available to the public. We're seeing community benefit shared coordinated efforts. We're looking in Maryland, hospitals are required to invest in defined public health goals, including social determinants of health. Some states are looking this session about mandating how community benefit dollars are spent and minimum expenditures. We're looking at New York, Montana, Oregon, and others, and there's a variety of methods that they are using. Illinois has taken a little bit different look at lowering hospital costs for low income and uninsured. And then we're also looking forward to California's initiative, where hospitals and health systems will be required to submit an equity report starting in 2025. So there's a lot going on in the different states. And Dawn, I want to ask you, can you talk about community benefits? How do you determine what the benefit will be? And how do you invest in the community?
Sure. Well, thank you, Marilyn, and thanks to Kim and all the other leaders that are on this event. So one of the things that I think is important to do to set some context is just that, you know, Denver, and I'm very empathetic and love all of my colleagues in the rurals, but Denver as a overall community has social determinants of health across the board that create more challenges for the hospitals and the healthcare systems. As you can see on this slide, our percentage of the uninsured is greater, children in single households, food insecurity, and so forth. So these are really challenging things, but they're also opportunities. And I have to say, while the heading was hospitals, one of the benefits that Denver Health has is that it's more than a hospital, it's a healthcare system. And so we have 10 ambulatory clinics, 19 school-based clinics spread throughout the city. Now, why that's important, as you all know, is that we want to prevent some of the health conditions that result in hospitalizations. And that, you know, is not only good for the patients that we serve, it's good for the Medicaid budget because we would like to shift care more to the ambulatory setting. We have no problem defining our uncompensated care and our social determinants of health and how that all rolls up into community benefit. Our uncompensated care actually doubled in the last 2 years. And so that's a significant factor being driven by a few things. One, more people who are coming in that are we're providing uncompensated care for. More complex medical conditions, quite frankly, substance abuse, mental health conditions that are manifesting themselves in a number of ways. And labor costs, which I think you're all aware of, that the cost of providing care, particularly in the nursing area, has escalated over the last several years. So that has resulted in some real challenges and actually an increase in our community benefit spend. 55% of the patients that we see are at or below 100% of the federal poverty level. And unlike most hospitals across the state, our payer mix is significantly different. And, you know, the health expenditure reports that HCPF issues, you know, have a 50% commercial population across the state. We only see about 15% of our patients having commercial insurance. And then on the flip side, with about 17% of the patients across the state having Medicaid, at Denver Health, we're at about 50%. 20% of our patients experience homelessness, and our hospital stays as a result are twice as long for that population. We are 85% higher in terms of readmission rates for that population as well. So, Marilyn, I had to give the team on the call that introduction, so they really understand, you know, what is happening at Denver Health. So, because the social determinants of health are so important, and I think we can go to the next slide. Because the social determinants of health are so important, we invest a significant amount of money. I jokingly said to one of my colleagues, our new name should be the Denver Health and Housing Authority, not the Denver Health Authority, because we are spending a tremendous amount keeping patients for longer lengths of stay because they are homeless, and readmitting patients. And so there's a delicate balance between the work that we're doing to make sure that we are providing good health outcomes, which is part of our mission, and I think every hospital's mission. So we've got to manage a variety of things. We need to serve our community. We need to balance some of the workforce shortages that we're all experiencing. Of course, we want to focus on affordability, but we also have to talk about quality, which we haven't so much covered in some of these segments. But I don't think, you know, we can do the work that we do as hospitals and healthcare systems without focusing on quality. So this is what we do. This is who we are, trying to balance all of those elements. We did lose money in 2022. My hope is that we don't do that in 2023. We have some plans to do that. So as you can see, the 120 million that we have in uncompensated care is complemented by a number of areas where we want to improve the well-being of our children. We actually have a number of mental health programs that support children in the community. We do social needs screening in our pediatric visits. And then we often raise money for some things that we don't get compensated for, but we know complement traditional medical care. We have a Center for Addiction Medicine. We are working with Colorado Access on some of the most difficult patients that we have. You may not be aware, we have a program called Denver Cares, which is a non-medical detox. And for patients who come into that non-medical detox 50 or more times a year, we have a very intensive outreach program. So I would put a lot of these things into the bucket of community benefit. And as you can see, behavioral health is really the biggest area where we're spending money now, whether we're spending our own money or we're pursuing grants to help the patients that we're seeing. Food partnerships are also really important. We're also, as I said, on the housing side, I now have 29 respite beds that are outside of the main hospital campus. And so we're paying housing agencies for those beds because it is cheaper for us to pay for the beds and get people housed, temporary housing up to 3 months, than it is to retain them in the hospital. What we want to do in the hospital is make sure that we're dealing with acute needs. The last thing I'll say, and then I think we'll go to the next slide, is that, you know, economic opportunity as a large employer in Denver is very important, not only for the existing staff that we have, but also to bring people in from the community. We can go to the next slide, I think.
Yes, thank you, Donna. Thank you so much for that overview. Now let's, Nancy, can you talk to us a little bit about what the department did with the 2023 community benefit reports, what you found, what action you're taking?
Yeah, excellent. Thank you so much, Marilyn. Absolutely. And good morning to you, Donna. It is quite a pleasure and privilege to be here with you this morning and to hear about what Denver Health is doing in this area. Thanks to House Bill 1913-20, all of Colorado's nonprofit hospitals, urban larger ones, report their community benefit spending directly to HCPF, and then we report that out to our General Assembly each January. So on this slide here, you see some information about what was included in our January 2023 report. And this reflects generally 2020 information. For some hospitals, it was 21. So you can see hospitals invested $965 million, or 7% of their patient revenues, back into the community. Under this state law, we are excluding the Medicaid, what we call shortfall or unreimbursed costs for Medicaid, because from the state perspective, we're particularly interested in community benefits in addition to that care for Medicaid members. You see here that about 25% was focused on charity care, 55% on health behaviors or risk, and that is investments in programs that support or maintain healthy lifestyles or manage chronic disease like mental health treatment, maternal health support. 8% into social determinants of health, which of course, Donna, you spoke about quite a bit there, things like job training, housing, education support, transportation, and then another 12% that were reported into other community identified needs. Let's go to the next slide, please. Thank you. We do, of course, see that there are still some opportunities to improve community investments, particularly around aligning the community dollars spent, making sure that what the community is voicing are the needs are reflected in the hospital actions, and improving reporting on the initiatives and dollars. As you saw on the previous slide, we really have 4 big buckets that we are getting information in, and we would like to have more finite information, like how much is going to behavioral health, how much is going to housing supports. We also want to make sure there's a more robust and definitive community engagement, as well as compliance enforcement. A bill has just been introduced this week, House Bill 23-1243, which addresses these opportunities, and discussions are in process, and we would certainly invite input on that bill. And with that quick overview there, I'd like to return this back to you, Marilyn, for the next slide.
Thank you. Next slide. Thank you. Let's take a look at the total health system landscape. Investments. Hospitals do have investments. And in 2022, we all saw the market decrease, especially if the system was heavily invested in equities. The first 3 quarters were tough, but there's a turnaround. And the chart you see shows the turnaround in the investment in fourth quarter 2022, CommonSpirit increasing 719 million, UC Health 308 million, Advent Health 217 million. So we're seeing that swing back. Workforce wages, as we've been talking about, have been a concern with hospitals, have been an issue. We had a massive increase in staffing agency reliance, contracted staffing in 2021, 2022, but we've seen a turn of that towards the end of 2022 that decreased the number of workers and the hourly rates at these staffing agencies. Significant increase, though, in the overall frontline workforce wages. As we look at the trend, we've looked in other states, those wages have been fairly stagnant, and we have seen an increase in that. So hospitals do continue to work with wages and managing the staff. Mergers and acquisitions are still in the forefront. We're seeing continued mergers, acquisitions in Colorado, Intermountain and SCL, that merger. Right now, the statistics are showing us 70% of physician practices are now owned by hospitals, health systems, private equity firms, and other corporate entities. We see that the prices, that is the price for the service of the physician, increase an average of 14%. And that doesn't include the increased costs that we're seeing in referrals. There is a Connecticut law that hospitals and health systems acquiring physician groups have to provide notification, and then they're moving forth this session with some type of review. 2023 looks better on the financial turnaround for hospitals. Fitch released their recent report on not-for-profit hospitals, noting that many that were operating fairly well by the end of the 2022 year and we're bringing on operating profits. They note that 2023 is a turning point. They project many providers will be able to at least break even in their operations on a month-to-month basis before mid-year, generating a profit, operating profit by the end of the year. So that was good news. Next slide, please. So Nancy, tell us what your department has seen on the financial front for hospitals. Next slide, please.
Yeah, absolutely. Thank you, Marilyn. So Colorado certainly agrees that, transparency is important, and we are really appreciative of efforts and engagement of hospitals since we began measuring hospital costs, prices, and profits through other legislation passed in 2019, House Bill 1001. The department collects financial information from hospitals, and this allows us to compare Colorado hospitals to other hospitals across the nation and allows us to understand the financial health of our hospitals and see their trends over time. As we review Colorado hospitals' price, costs, and profits on patient care, the profits on patient care is the payments received for that care versus the cost, and total profit, we see that Colorado hospitals have ranked high in each metric since 2018. But in 2021, the most recent year that we have data for on all hospitals, we see improvement in that cost of patient care. But without a reduction in prices, the profits are remaining high compared to the nation. There is a proposed Representative Soper and Kennedy are bringing a bill, House Bill 23-1226, which will provide more frequent data for us. And we can go to the next slide. And then speaking of more frequent data, today we are publishing a Hospital Insights Bulletin, and that includes a preview of 2022 data through the third quarter. So that's through September of 22. This information shows the days cash on hand, which is the number of days hospitals can continue to pay their operating expenses, given the amount of cash they have available, and reserves for consolidated national systems that are operating in Colorado. And this information we have here is from 2019, again, through that third quarter of 2022. This is the 2022 data, again, is on the national systems. We won't have individual hospital data until next year. We see that the rainy day funds were not used as much as may have been anticipated with the pandemic. And Colorado's urban and system affiliated hospitals maintained a median 225 days cash on hand in 2019 compared to 245 days in 2021. As we review the data, though, we are particularly concerned about the losses for Denver Health. Donna spoke about that a moment ago, the challenges in 2022. And we know that Denver Health is currently operating on less than 100 days cash on hand. And we're also looking at the reductions in reserves for UC Health in 2022. We understand those may be largely due to investment declines, as well as returning advance payments to Medicare. Now, these numbers don't include that fourth quarter of 2022 market pickup that Marilyn mentioned a moment ago, nor do they include the first quarter of 2023. So as the full year of 2022 is available, that will further illuminate the current financial situation of our hospitals. And if we could go to the next slide, please. Great. On this slide, this shows the days cash on hand on a line graph, again, for the overall systems. And then the cash reserves are the values for 2019 at the left and that third quarter 2022 at the right. One thing that you are able to see here is that the value of reserve dollars needed to cover the same days cash on hand increased between 2019 and 22. 4 systems are up or the same and 3 are down when you look at those reserve dollars. When you look at days cash on hand, 5 systems are down or 2 are up. So bottom line is, as operating costs increase, more dollars in reserves are needed to have the same days cash on hand over time. Great. And then next slide, please. Excellent. And then in addition to that new insights report, today we are introducing a new break-even analysis tool, which helps employers and other payers better understand hospital prices. This is a very short preview of that tool. Certainly invite you to reach out to me and my team will teach you how to use it. And we also intend to later this spring host a webinar to provide a demonstration as well as answer questions. This tool provides financial data from 2012 through 2020 with an emphasis on Colorado hospitals, but also includes thousands of hospitals nationwide. It allows us to compare commercial payment rates hospitals currently need to financially break even, and compare that to national and state benchmarks, and also compare it to what Medicare pays. The purpose of this tool is not to suggest hospitals should only break even, but rather by looking at what hospitals are charging now above the break-even point and being able to reference that to Medicare rates and to how that compares to other hospitals nationally, it helps provide information for employers and payers to better understand hospital prices. And with that quick preview, as we go to the next slide, I will turn it back to you, Marilyn.
Thank you, Nancy. Hospital price transparency is in the forefront nationally and in Colorado. Colorado led the way with your bill in 22 to require hospital price transparency, and a hospital that didn't do that would not be able to do the balance billing. We are seeing it take off in other states. In fact, right now, currently, Ohio has a hearing going on a similar bill. And I've listed some states there that are moving forward with similar bills. Indiana has a proposed bill that would create civil penalties for not posting pricing information. So what happens when that information is posted? One thing that has popped up is Lehigh County, Pennsylvania, had an audit done comparing the hospital posted prices to what they were paying for their plan, and found that in most cases, on large items, the cash price or the uninsured price was actually higher or lower, than what they were paying. They have projected they will save $4 million by doing a direct contract with 2 different hospitals. We are finding many times the cash price is lower. Excuse me. So Nancy, can you talk about what Colorado's doing?
Yes, absolutely, Marilyn. Thank you so much. Thank you for going to the next slide there. So today we have also published a hospital price transparency posting evaluation report. You've got the link in the chat as well as the bottom of the slide here. What we've done is from October 17th through November 9th, 2022, we reviewed 83 of Colorado's general and acute and critical access hospitals, downloadable files, and shoppable service estimator tools or displays. Quite the mouthful. This follows the federal requirements of what hospitals must display in terms of their pricing for the public. We evaluated each hospital using a scorecard. The categories in the scorecard reflect the checklist of the different areas that the federal government is reviewing in terms of compliance with those federal regulations. With our scorecard, we marked a yes if it meets the federal criteria or a no if it doesn't. And we developed a good, fair, poor rating that measures the quality of adherence to those federal price transparency rules. Again, it captures that federal checklist for hospitals. On this slide here, you see a review of Colorado hospital systems. Our published report also includes a scorecard for each Colorado hospital reviewed. And let's go to the next slide, please. Great. So this is showing this information kind of at a high level grouped by hospitals. Please note that the federal regulations required all hospitals to report their prices by January of 2021. And then the House Bill 22-1285, which you spoke of briefly there, Marilyn, doesn't create greater incentives for hospitals to comply. And that state law was effective for our critical access hospitals last month. As you see, as of November 9, 2022, 26.5% of Colorado hospitals and 31.1% of system hospitals, we had an overall quality rating of good. And just to note, low score for hospitals are primarily due to not listing the individual payer products or healthcare plans. And so that is something that typically for our quality rating resulted in a lower score. HCPF analysis and comparable studies on federal transparency certainly show there's an opportunity for hospitals to improve. And we understand that Colorado hospitals are improving their postings and with support from the Colorado Hospital Association. And moving forward, we plan to evaluate the postings and publish this scorecard twice a year. And with that, thank you so much to Marilyn and Donna. And I believe I am ready to turn this back over to Executive Director Kim Bimsteffer.
I think there's one more question from Marilyn, is there not? You're on mute there, Marilyn.
About that. Excuse me. Thank you, Kim. Donna, I want to ask you, how do you balance everything? We've covered community benefit. We've talked about quality. We've talked about access. We've affordability. How do you balance everything?
That's a great question. And it's getting harder. But, you know, we do have, you know, again, back to Kim and to the state overall, the state has been very supportive of us. One of the things that's unique about Denver Health is, despite the fact that we're called Denver Health, we see patients from 63 of our 64 counties. So the relationship with the state is very important. The relationship with the city is also important. But we've made some trade-offs, and I'm glad that Nancy pointed out some of the trends. I mean, our traveler costs in 2020 were 53 million. We're hoping to cut them in half this year. And part of that is paying the existing workforce, you know, not only a wage that's comparable, but recognizing, as I said, the patients that we're seeing here at Denver Health are much more complex than the overall system. So it is a balancing act. As I said, this year will break even, but break even isn't a long-term business strategy because we need to invest more in IT. And as I said, we're very focused on quality and service and access for our patients. I will tell you, access is really challenging right now. So there's some work we do too on efficiency through lean. So I think it's all those component parts and how, you know, as I said, I think one of the really fortunate parts of being at Denver Health is that we do see patients when they first need care. And I can't emphasize too the work that we do in the schools and trying to tackle some of the problems that children have. And I think it's a wonderful both service to the state and the city, but we know that our children are also seeing, you know, more stresses, more substance abuse, more behavioral health issues that partly were a result of COVID, but other societal factors. So it is complicated, but it's part of, I think, what I signed up to do and a lot of hospital CEOs sign up to do. But really leading with service and quality for me and being focused on the patient is the most important part of what we do. We obviously have to be, we have to improve our days of cash on hand, as Nancy pointed out. But affordability, my obligation, I feel like as an authority of the state, my obligation is also to make sure that care is affordable.
Donna, thank you so much. And Nancy, thank you for the panel discussion. Turning it back to you, Kim.
Yeah, thank you so much for Marilyn, Nancy, Donna, bringing your amazing expertise. That was jam-packed. Thank you, thank you. And I do want to underscore, Donna, we do have admiration, great admiration, for we know hospitals and physician groups are, you know, battling every day to drive affordability, to save people money on healthcare and employers money on healthcare, to drive quality, to meet the needs of the community, which could be community benefit, could be access, equity, affordability, quality. All those things are so important. Thank you very much to you and all the hospitals for what you're doing to partner with the department and with the state to drive a better tomorrow. So thank you. So with that, before we go on to our next session, we want to take a 30-second or 1-minute break to hear a little public service announcement about Connect for Health Colorado.
Coloradans always live life to the fullest. Whether tending crops on the Eastern Plains, skating at the neighborhood park, or riding off into the western sunset, opportunities abound for fun times in the great outdoors. That's why Connect for Health Colorado works to get you the best available health insurance plan for the right price. Our experts can help you for free every step of the way so you can focus on what matters most, like always getting the shot. Enrollment is open now through January 15th. Live your best life, Colorado. We've got you covered.
So that tees up this next session, which is so important. So this session is about a collaborative, united effort to achieve a shared goal, which you can see on the screen, which is to keep Coloradans covered as we enter the end of the public health emergency, and for Medicaid, the end of the continuous coverage period. As you know, the federal government has said, keep everybody covered through this COVID pandemic. And we have done so. And even if people were not continually eligible for Medicaid, we kept them on the rosters at the direction of our federal government, and as an honor to take care of people during this period of time. The uninsured rate has stayed at 6% through this entire pandemic, which is just a spectacular contribution and outcome. And that's as a result of the hard work of a whole lot of people, and many are listed on this slide and others as well. But just a shout out to the work done to date, the work done through the pandemic, and all of the work that we're doing now to continue that fabulous track record of keeping Coloradans covered. So I want to just a quick shout out, all of our healthcare providers, counties, regional accountable entities are raised, Connect for Health Colorado, consumer advocates, health plans, our elected officials, the administration, all our departments and state agencies, just spectacular achievement to come. Now, the goal going forward is, in a nutshell, about 80% of our 1.75 million Coloradans that we cover now with our safety net programs, our data and insight indicates about 80% should renew, but they have to take action to do so. So to keep Coloradans covered, our shared goal is to make sure that that 80% fills out the forms, reacts, and does the things that they need to do, including updating contact information, looking for that renewal packet, signing it, and getting it back, so that we keep that 80% covered. And our other challenge is to take the 20% who would be disenrolled and connect them to affordable coverage. So that is the goal we're trying to do together. And an estimate of that a group of individuals that will no longer be eligible for Medicaid or the Children's Health Insurance Program is estimated to be more than 325,000 people. So with that, let's turn it over to the next slide, please. And I'll introduce our distinguished panel again. I get the privilege of moderating this panel. We have Lisa Para, who is inside our eligibility area of our Medicaid Operations Office. We have Rachel Ryder, who oversees and is on our senior executive team and is over communications for the purpose of this conversation. And Director Michael Conway is here with us, as well as Commissioner of Insurance. And as I said with Donna Lynn, if you don't know Commissioner Conway, you may have registered for the wrong summit today. So with that, let's go to the next slide, please. And I'm going to turn this over, please, to Lisa.
Good morning, Kim. Thank you very much. Hello, everyone. Thank you for joining us today. If I could have the next slide, please. My name is Lisa Para, and I am the Eligibility Division Deputy Director here at the Department of Healthcare Policy and Financing. I touch briefly about Colorado's goals for the end of the public health emergency. As Kim had mentioned, starting in March of 2020, and throughout the COVID-19 pandemic, many Coloradans who lost their jobs and subsequently their employer-sponsored health benefits did turn to Health First Colorado. And as a result, Health First Colorado and CHP Plus now provide coverage to more than 1.7 million Coloradans, or 1 in every 4, and that includes more than 500,000 of Colorado's children. On December 29th, the federal government passed legislation ending the continuous coverage provision that's been in place since March of 2020, so 3 years now. And following guidance issued by our federal partners, the Centers for Medicare and Medicaid Services, or CMS, after more than a 3-year pause, the department, in a joint effort with our county partners, is resuming our standard eligibility renewal and disenrollment processes for Medicaid and CHP Plus. The renewal process will continue month by month through April of 2024, so for the next 14 months, for every member according to their renewal date, which means that we are beginning to send renewal notices and related information now to any member scheduled for renewal in May of 2023. To many of you attending today's summit, I echo Kim and thank you for your ongoing collaboration throughout the public health emergency. And this especially includes our county partners who have worked so hard on behalf of Coloradans. Colorado is focusing its unwind planning on achieving 3 really key operational goals. The first is to maximize member continuity of coverage. The second is to focus on the member experience and smooth transitions in coverage. And then third, to minimize impact to our county and eligibility workforce. In preparation for the end of the public health emergency, the state's made meaningful systematic advances over the last few years, so that now about 1/3 of our current members will be automatically renewed and they won't need to take any action at all to remain covered. We've enhanced numerous business processes, enhanced our online tools, and made correspondence improvements to make it easier for our members to renew coverage. And we've worked to secure additional funds to assist our counties through this unique chapter. Colorado's been preparing for the end of the public health emergency for nearly 3 years. So as soon as we started making changes, we started thinking about how we would unwind our changes. We're doing everything we can to meet that #1 goal of continuity of coverage. Our partners at CMS have recognized Colorado as a leader in our preparation, and they're confident, and we are confident, with the steps we've taken to ensure people stay covered. If I could have the next slide, please. As Kim had mentioned, we estimate that about 80% of our current members will still qualify for one of our programs between now and April 2024, and we are focused on ensuring that those Coloradans know exactly what actions they need to take and that they take those required actions to facilitate their coverage renewal. Rachel Ryder, our next speaker, will go into more detail on how we're doing that, but our partnerships, our collaborative efforts right now are critical as we work together to renew the estimated 1.4 million Coloradans back onto our programs, while connecting an estimated 325,000 Coloradans to other forms of affordable coverage. So with that, I'm going to turn it over to Rachel Ryder on the next slide, please.
Thank you, Lisa. My name is Rachel Ryder, and I am the Policy, Communication, and Administration Office Director at the department. I had the honor of overseeing the communications and government relations and legal teams. Today, I'm going to focus on all of the wonderful collaborative work that we've done from a communications and outreach perspective to get ready for this very important unwind of the public health emergency, specifically the continuous coverage requirement. So on this slide, you will see a few resources that the communication team here has developed in partnership and with our members and others that focus on kind of 3 key areas. And really our ask today is for all of you to continue to help us get the word out. It's so critically important as we go to this next phase, as we're sending out notices for this first cohort of folks who are renewing. On this slide, you see some examples of 3 kind of phases of our campaign. The first piece here, and we've done some videos in English and Spanish for folks, and have toolkits that match up with all of these different initiatives. This first phase was update your address and continues to be critically important. And I want to say a huge thank you to the county and community partners who have helped us with this effort over the last year. I remember presenting at this last year and talking about the importance of update your address. We've had many members update their contact information and have had a 34% increase in the number of folks who have actually signed up for e-notices, so we can reach them more effectively with email and text messages as we're getting to this critically important phase. So as Lisa mentioned, our primary goal is to make sure that those folks know who are coming up for renewal know when to take action. So this next phase of the campaign is take action on your renewal and really getting to know what the renewal process is. So we released last fall some educational videos and materials and toolkit to help folks understand what the renewal process looked like, including sample notices and letters, and those are highlighted in our video here and in our take action or get ready to take action on your toolkit. So I encourage all of you to become familiar with what the renewal process looks like. The department will be partnering, as Kim and as Lisa have mentioned, very closely with Connect for Health Colorado, with the Division of Insurance, with many other partners as we go through this process. The department is working hand in hand with our regional accountable entities and health plans to make sure that our members know when it's their time to take action. So this next slide will highlight our take action on your renewal toolkit. So this we just released about a month ago, and this aligns with the urgency and messaging of it's time to take action now. So what we want to emphasize with everyone on this call and with all of our community partners and our members is that not everyone will be renewed at once. Colorado is taking a very responsible, reasoned approach to doing it over 14 months with noticing. It's 12 months total, but 14 months with noticing, to ensure that our members are renewed at the time that their renewal is due, so their annual renewal date. So we will be doing this over the coming 12 months, 14 months with noticing. Our notices going out in March. They just went out, and the outreach will start to those individuals to do follow-up and make sure that they take action on their renewals here in the coming months. So that is the phase that we're at now, and we really want to make sure that folks know that you can take action, and the Take Action on Your Renewals toolkit is up. And then when it's your time to take action, the department will be reaching out to you, and our health plans will be following up that outreach. The next slide, please, kind of highlights some other materials that we just released, and want to make sure that you all have these materials and understand how to use them. And if there are materials that you would like to see that are not included in our toolkits, we're adding to these toolkits all the time. So this new initiative, as you can see by our backgrounds in this, that Lisa and I's backgrounds in this particular presentation, we are really focused on this cross-department or cross-agency, cross-state effort to keep Coloradans covered. And what that means is we are focused on renewing those folks and enrolling them back into Medicaid and the Child Health Plan Plus if they're eligible. But we do know it's critically important for those estimated 325,000, more than 325,000 folks to be connected to other coverage for which they're eligible for. So that could mean that they're eligible to become, to enroll in their parents' plan if they're age 25 or under, or if they have a spouse that has an employer-sponsored plan, or potentially some of those individuals could already be enrolled or take advantage and enroll in their employer-sponsored plans if they're no longer eligible for coverage for Health First Colorado or the Child Health Plan Plus. We do know that some of those folks will absolutely benefit from receiving some reduced cost plan options on the exchange. And so you're going to hear from our partner over at the exchange here in just a minute about what they're doing to get ready. And we are coordinating very closely with our exchange partners, the Division of Insurance, to make sure that folks know what they're eligible for and know to take action. So the next slide, please, gives an example of how you can help us. Right now, we have a flyer that you can download. There's a QR code here, and it highlights some of the various options for coverage if you're looking for coverage. So this helps us get the word out, and we really encourage everyone on this call to take a look at these resources, including this flyer, and think about, could I post this in my provider office? Could I put this in my county office? We're working very closely with all of our county partners to make sure that they have messaging and resources that make sense for their spaces. So with that, let's go to the next slide, please. This is an example. As I mentioned, some folks will be transitioning to employer-sponsored coverage. Health plans across the state are stepping up to get the word out and let folks know about the Medicaid renewal process and let them know where to go for options if they no longer qualify. So this is an example from Anthem. Next slide, please. So in short, and there'll be a poll that pops up here in a minute for you all to take take here. But in short, we have a few asks for you all. Thank you, one, for joining us. Thank you so much for the support that you've given to us in the last year in the Update Your Address campaign. We have seen significant increases in folks taking action on that. And now we're at that point in time when we really need folks to understand when it is their time to take action, what they need to do. So we have messaging up on our website. We have direct-to-member communications, and then we have many other awareness building initiatives that are happening, many of which are highlighted in our toolkit that I went over here just a minute ago. In addition to that, as a key stakeholder, we encourage you to sign up for our COVID newsletter, where we'll be monthly giving updates on the unwind, releasing new materials, and sharing best practices and outreach to make sure that we do keep Coloradans covered. So with that, I think I will hand it over to my partner over at Connect for Health Colorado, Ezra.
Great. Thanks so much, Rachel. Good morning, everyone. Great to be with you. I am Ezra Watland, the Director of Marketing and Communications for Connect for Health Colorado, the state's health insurance marketplace. And I'm here to talk with you about what the next phase of this transition will look like. So Rachel and our prior panelists spoke about all of the work that will be underway to support people in retaining their coverage through Health First Colorado, if that's the program that they're eligible for. We at the exchange are really focused on making sure that we help individuals who are no longer eligible for those programs come over to us and make sure that they can continue their coverage. So on the next slide, we can talk in a little bit more detail about what that customer journey is going to look like. This is just a really high level summary of what customers can expect and how ultimately they can come to us to make sure that they retain coverage. So the first thing that is going to happen is they will receive a notice from HCPF that they are no longer eligible for either Health First Colorado or the CHP Plus program. At that point, they have an opportunity to shop for coverage. And they can do so through us at our website, connectforhealthco.com. They'll have a pretty lengthy window of time to be able to do that. There is a special enrollment period that will allow them to shop for over a year if they choose to do so. But a huge part of our focus is going to be getting the word out to them as early as possible so that as much as possible, we can help them minimize the risk in having a gap in coverage. We're going to leverage our statewide network of brokers and enrollment assisters to help us through that process and to ultimately help customers enroll in coverage as smoothly and simply as possible. That shopping process can happen through our website, starting on the first day that they're eligible to shop in their special enrollment period window. And then ultimately that will help them make sure that they retain coverage for 2023. On the next slide, I'll go into just a little bit more detail about how we plan to implement this strategy. So ultimately, we have a two-pronged strategy, which is really focused on first building awareness, making sure that customers are aware that they need to take action, and then second, making sure that we ensure the enrollment process is as simple as possible. I'll talk about the process of creating awareness first. So the process that we have in place is really focused on making sure that we have both direct and indirect communication plans in place. First, on the direct communication process, we are working closely with HCPF to make sure that we know on a regular basis who specifically is no longer going to be eligible for Health First Colorado. When those individuals are no longer eligible and they've received notices from HCPF, we'll have an opportunity to do some outreach to them as well. We'll have the opportunity to send them emails, do some direct phone calling, or send them mailers to help inform them of who we are and how we can help them enroll in health insurance. We also are going to need help making sure that we get the word out as far and wide as possible. And so where you all can help that are on this call is making sure that we share information that we have available about who Connect for Health Colorado is. One of the biggest barriers that we'll have initially is just awareness. So where people can receive information about us and make sure that they understand who we are and how they can enroll through us, that's going to be a really huge help in getting the word out effectively. On the other side of it, once we've created some awareness about how to enroll through us, we want to make sure that that process is as simple and straightforward as possible. One of the ways that we're doing that is by starting before customers even come over to us on the Connect for Health Colorado side. So we are collaborating with our partners in the regional accountability entities across the state to make sure that they understand who we are, who our network is, and they can help their customers build that awareness once it becomes clear that they may no longer be eligible for Health First Colorado or CHP Plus. That'll be a huge help before our outreach even begins to make sure that customers who are extra interested and proactive have the ability to get started before our additional communications start to go out. The additional resource that we'll tap into, like I mentioned earlier, is our statewide network of brokers and enrollment assisters. We also have some extra funding that is going to be available for both that network as well as some of the direct outreach efforts that we have underway, thanks to a bill that was passed last year through the General Assembly, Senate Bill 2281, which provides up to $4 million a year in donations from our insurance carrier partners. That can come over to us specifically allocated for outreach and marketing purposes. And that will be a really great resource that we have available to make sure that we can spread the word even further. Jumping to the next slide. This gives you just a little bit of a snapshot of what our customer communications will look like. Specifically, one of the major resources that we'll have in place is direct emails that will go out to introduce ourselves to individuals that need to make the transition off of Health First Colorado to new coverage. So we'll look to do that through emails that are geared toward being simple and straightforward, offer kind of colorful and eye-catching branding to hopefully entice people to take a closer look. And then we'll have links that drive to our website that provide simple, straightforward information that help people get started through the process. The main goal is to help drive them to get a little bit more information so that they feel confident and ready to start the application process through us. On the next slide, this is where some of the resources that I mentioned earlier are going to be available for you to receive. We have a store that has resources in both English and Spanish that are free to you. We cover all of the costs of printing and shipping those for you. And these, again, are just a really tremendous resource and way for you to help us make sure that we're building awareness. One of, again, the biggest barriers that we have is making sure that customers know who the state health insurance exchange is and when they can start shopping with us. So where possible, we certainly encourage you to visit our store and to request some of these materials that we'll make available throughout the year. As I mentioned earlier, we are really fortunate to have some extra resources that we can use for marketing and outreach purposes, thanks to Senate Bill 2281, which passed last year, and will continue to help us increase the amount of marketing and outreach that we can do throughout this Medicaid and online process.
Thank you, Ezra. Why don't we jump to the next slide? That was really a really great review. And I want to also just personally thank you for your tremendous partnership, Connect for Health, with all of the state agencies. Many of us sit on the board of Connect for Health, but it's really been spectacular. And we need those sort of collaborative partnerships to get through these times of significant member transition or Colorado transition into coverage. So now we'll turn it over to Commissioner Conway.
Good morning, folks, and apologies. Timing is always perfect, and somebody just rang my doorbell, so my dog is going nuts downstairs, but hopefully you can't hear that. So just going to talk through a few things, but before I do that, let me kind of a quick shout out to the HCPF team, folks. There's a ton of work that goes into things like this morning, and it's going obviously very seamlessly, and that's it because of Kim and her team's fantastic work to make sure that things do go seamlessly. So awesome job on that front, folks. So Ezra touched on really these first two things that I wanted to talk through a little bit with you all. But I'm going to go into just a tiny bit more depth on the first two, and then we'll talk a little bit about the Colorado option as well. So the special enrollment period that Ezra touched on. So it is going to be for essentially the entirety of the unwinds. So all the way through into 2024, folks that are unwinding, that are unwinding off of the PHE as a result of the end of the PHE, are going to have the opportunity to enroll in healthcare coverage through the Connect for Health Colorado for that entire time. Now, we want folks to go out and shop and choose a plan as soon as they possibly can so they don't have that gap in coverage. But we're doing that in large part, folks, because we understand that there's going to be a lot of confusion for people as the unwind is happening. They may not understand that they no longer have coverage through HCPF, through Medicaid, and we want to give them opportunities and time to go and find the solutions for them that work best. A number of them are going to have coverage through their employers and opportunities for coverage through their employers, but that won't be everybody. And we want to make sure that by working through with Connect for Health Colorado, people have as ample of an opportunity as possible in order to actually find the coverage that works for them. And that's not just happening here. The federal government has followed suit, and they're going to do the same thing on the federal marketplace. They're going to have essentially a rolling SEP for people that are rolling off of Medicaid at the national level too. It's at least our expectation that many of the states that have the other states that have their own exchanges like we do will follow suit as well. And it really is because of that recognition, folks, that this is going to be a confusing time for people. But what is most important is that we keep them covered, because coverage, especially in this country, obviously equates to access to care, and access to care is what we're all shooting for. The other piece that I think is going to be really important for people is this second bullet here, the Connect for Health Colorado financial assistance. So number of these people have obviously been enrolled in Medicaid for the last 3 years, as Kim walked through. In that period of time, there's been enhanced subsidies that have come into play, both because of laws that have passed in Colorado, but also because of laws that have passed at the federal level. So for those folks that maybe were enrolled or had coverage, at least at some point prior to the Medicaid emergency, they're going to, if they go back to Connect for Health Colorado, they very well may find out that they have those enhanced subsidies that will make coverage even more affordable to them than was the case when they were enrolled previously. So we really want to take the time to get that message out to them and really work with our broker partners as Ezra and others touched on earlier, our broker partners and our sisters throughout the state to help get that message out. The Inflation Reduction Act enhanced subsidies. We passed laws in Colorado that are being implemented, and as a result of that, people have, for certain income brackets, have help with their cost shares to reduce their cost shares. So that people are going to be eligible for those plans, and we really want to make sure that they understand that that help and that assistance is out there for them, and that's going to take some time too. And that's another reason why, going back to that first bullet point, why we think the kind of rolling special enrollment period is very, very important. Then the last piece, the Colorado option, and I know Kim, I'm trying to keep you on time. I know we've got till 9:25, and then you got to get to your next.
You're doing great. Do your thing. You're doing good.
So on the Colorado option. So obviously we are in year 1 of implementation of the Colorado option. And what we found in year 1 is that it was a very, very popular plan, much more popular than what I was expecting, candidly, folks. Almost 14% of the people that shop for coverage on Connect for Health Colorado picked the Colorado option plan from one of the many, all of the carriers on the exchange that are offering the Colorado option plan. As a comparison, the only other state that has a public option-like product in their marketplace is the state of Washington. And the state of Washington, in their first year, they only had about 1% of their enrollment actually going to their public option product. So we're very excited about that. We know that means that people, if they can find the Colorado option when they shop for it, then they're choosing that option, and that's because a few reasons. We know that because we worked with many people that are on this today to build out the Colorado option benefit plan. It's really kind of the only benefit plan in our marketplace, at least, that had community involvement in building out that benefit plan. Community involvement both from consumers, but then also insurance companies and providers too, to make sure that we were building a product and a benefit structure that meant that people were going to be able to use it. And by using it, because of the way that the option was built and the great teamwork from the folks that are on this call, people are going to be able to go when they go primary care visits, first dollar primary care visits, first dollar mental health visits. There's enhanced benefits for people that have diabetes. There's enhanced benefits for post and prenatal care. So there's the benefit package itself is going to make it more appealing, we think, for people that are rolling off of the PHE to enroll in the Colorado option product. And we want to make sure that we're building out that benefit further, and we're going to continue to have conversations, but we really want to make sure that we're making it easy for people to find that plan. And that's one of the bills that we're working through this session, House Bill 1224. This session is part of that bill is designed to do exactly that, to make it easy for people to shop and find the Colorado option plan, because we know it's going to be really important for people as they roll off the PHE to find products that are meaningful to them and provide benefits that they're going to be able to use. And we know the Colorado option does that, and the other products that are on the exchange do as well. But we really want to make sure that we're making it easier for people to find the Colorado option product. Kim, with that, I think I will kick it back to you, and you can go on to your next panel.
Well, I appreciate that, Mike. Thank you again for your partnership and amazing leadership. Truly, I know the whole state appreciates who you are and what you do every day. To the entirety of the panel that we just had, this is such an important time of getting all of these 1.75 million individuals to do what they need to do to keep Coloradans covered. We want to avoid at all costs any consequences to individuals going uninsured, and we want to make sure that those that lose coverage because they're no longer eligible for our safety net, they get connected. And I really appreciate, Mike, your leadership on things like the Colorado option, because that delivers the affordability that we need. So well done. Okay, with that, we're going to transition to the next session. And, I'm sorry, I want to mention one more thing before we do. More than 1,000 organizations across our state have engaged with us to develop these tools, to figure out the strategies, and to do all the good work. And I do want to recognize that across the state, we're actually leading the nation on making sure we're doing everything we can. And CMS is frequently saying, can you teach others how you're doing communication plans? Can you teach others all the things that you're doing? In fact, we're one of only 12 states that was not asked by CMS to do corrective action and take corrective action steps to further the work that they're doing to make sure that we achieve our shared goals across the nation. So now I'm going to turn this over to our final session, and that is how the state is expanding and aligning value-based payments, which are such critical payment models because they reward providers for better patient outcomes, for closing disparities, and for driving affordability and increasing quality care results. And we don't want more of yesterday, which is paying for volume that gets us higher trends and paying more than other countries are. We want to pay for outcomes, and that's what value-based payments do. So this may include things like the hospital transformation program that Pete will touch on, our maternity bundles, prescriber tool, primary care, and more. So again, we have a distinguished panel. We have the Chief Medical Officer, Pete Walsh from HCPF, we have Trevor from our finance office, who works very closely with Pete, helping to lead our payment reform work here at Health Policy and Financing. And then from DOI, we have Tara Smith, who's a primary care and affordability director for the Division of Insurance. And so if I could ask Trevor and Tara to turn on your cameras, there we go. And let's go to the next slide, please. And I think we're going to start off with Pete.
Well, good morning. Next slide, please. I'm Pete Walsh. I'm a physician. I'm the Chief Medical Officer at the department, and Trevor will speak in a moment, and I'll introduce him. I'm just going to spend a few moments updating you on our efforts at the department regarding value-based payments. As Kim mentioned, the key objective here is a transition from a volume approach with reimbursement to one that focuses on quality, equity, and affordability. And while regarding quality, on the last bullet, you'll notice it talks about cost and quality indicators. I want to stress the importance that quality plays in this, and the fact that all of these programs will have a quality element in addition to a cost element in terms of how we incentivize payment. Our target is to transition to a 50% value-based purchasing approach by 2025. We're currently at approximately 30% of our reimbursements are based on VBPs. An example of that would be with regard to the hospitals is the hospital transformation program, which I'll speak to in the next slide. And that was preceded and still exists with regard to the hospital quality incentive program. An example with regard to primary care, we do have an APM1 and an APM2 model currently in place. With the APM2, on top of the quality element, we're transitioning to a capitation element, but quality will remain important. Tom Leahy spoke to some of the efforts around prescription drug programs, particularly the concept of including VBPs with regard to outcomes related to actual payments for the program. We have a maternity bundle currently in place that Trevor will provide a little more detail on. We're moving to, we haven't yet implemented yet, a behavioral health program which ensures safety net accountability. Nursing homes, we intend to move to a pay-for-performance model with an increased emphasis on quality. We have an ARPA program currently underway with regard to the PACE program. It's in the planning and design phase. And finally, I spoke to all of these are tied together by a set of quality metrics which focus on CMS core measures. And also one of our key objectives is to align with the DOI's efforts regarding value-based programs. Next slide, please. Regarding the hospital transformation program, it's in year 2 currently. In the blue section of this slide, you'll see some of the key emphasis areas that the program is designed upon. It's designed to improve basically avoidable utilization with regard to emergency department hospitalization. It has a focus on core populations and health equity. It focuses on substance use disorder and appropriately addressing it and providing treatment. It does focus on clinical and operational efficiencies, and it does encourage community development efforts, which we think are a key element of this program. It has a pay for activity, a pay for milestone, and a pay performance, I'll say, approach embedded in it. And we're very pleased to be working with hospitals on this program, and we look forward to its results in the future. Next slide. And with that, I'm going to hand off to Trevor Abeyta, who's our Payment Reform Division Director. Over to you, Trevor.
Thank you so much, Dr. Walsh. And today I'm going to talk about a few of the department's different value-based payment programs and how you can get involved. But mostly what I want to emphasize today is that value-based payments are a partnership between the department, our providers, and our members. So when we design value-based payments, we do this as a partnership between all of us. And so I'm coming here today with an open message of collaboration that we need your help to transition the department to value-based payments. And I know the link was shared linking you to the HCPF value-based payments website, but if you're interested in engaging and learning more, please check out our website and we're happy to connect with you and have your help as we make this extremely important transition. The first model I'd like to highlight is the prescriber tool shared savings model, which is our newest model, which begins on July 1st of this year. What this model does is it incentivizes use of the affordability module within a prescriber's workflow by sharing some of the savings with the prescriber. What's so exciting about this model is that in the first year of the program, participating providers will receive 100% of savings generated from the affordability module. And this is because the rising cost of prescription drugs is one of the most important focus areas of the department, and we want to help incentivize our prescribers to adopt the prescriber tool and incorporate this into your workflow. We have a series of informational webinars planned for April and May, and more information will be published on our website before those webinars. Next slide, please. The next program I'd like to talk about is for primary care, and this is our APM2 program. This is our primary care partial capitation. APM2 has two different payment components. The partial cap, which is a prospective upfront payment where primary care providers can choose to elect how much prospective payment they earn. And they can also receive shared savings for managing patients with chronic conditions. The department recognizes that it takes work for providers to transition to a value-based payment. And therefore, we have requested a 16% rate increase for providers who are participating in the APM2 program to help them make this transition. To further our commitment to helping providers be successful under a value-based payment arrangement, we are creating a suite of innovative tools that providers can use to be successful within a value-based payment. One of which I'd like to highlight is our e-consult platform, which primary care providers can begin using in early 2024 to improve specialty care and support, which will help to improve member outcomes and drive further shared savings for managing patients with chronic conditions within the APM2 framework. We currently cover 21% of Medicaid members through 117 sites, and it's growing every day of folks who are joining the APM2 program. Please consider joining the program now and participating in stakeholder engagement for program improvement, which will begin in July of this year. Next slide, please. The next program I'd like to talk about is payment alternatives for Colorado kids, and this is our pediatric APM. HCPF through Health First Colorado currently covers 43% of kids in the state. And as we created APM2 in partnership with stakeholders, it became apparent very quickly that APMs which work for adults may not work for kids. And so we committed to building a pediatric specific track of this program to help reward and support our pediatricians for helping kids to get off to a good start in life. The requested 16% rate increase, if approved, would apply to the PAC program too, recognizing the great work our pediatricians are doing helping kids here in Colorado. So we need your help to design this program. We're at the ground floor of design here. And beginning in July of 2023, we will begin engaging stakeholders to help us design this program with a targeted launch of July of 24. So we really need your help to do this. And if you're interested in helping to design the program, please get in contact with us and we're happy to have your help as we work through this process. Next slide, please. The last program I'd like to talk about is the work HCPF is doing through value-based payments to improve health equity and outcomes for birthing people here in Colorado. And we currently cover 25% of Medicaid deliveries through our existing maternity bundled payment, which rewards obstetrical providers for improving patient outcomes. We're looking to further evolve, though, our maternity bundle to further focus on closing persistent health disparities. So we're going to need your help to do this to make sure we get it right. And beginning in July of this year, we will be engaging with stakeholders to completely redesign our maternity bundle to further focus on this. So thank you everyone for having me here today. And I hope that you do reach out and work with us as we work to transition HCPF to value-based payments with a focus on improving outcomes, closing health disparities, and increasing affordability for the state. And with that, I will hand it to my colleague, Tara Smith at the Division of Insurance.
So thank you so much, Trevor. And thank you, Dr. Walls. Good morning, everyone. Again, my name is Tara Smith. I'm the Primary Care and Affordability Director at the Colorado Division of Insurance. I think I am in the spot of being the final speaker on the final panel, so I will do my best to bring us in both on time and with a strong finish here this morning. So really what I'm hoping to do this morning is just broaden the lens a little bit more around the value-based payment efforts that are currently underway in the state of Colorado. So Trevor and Dr. Walsh just provided us a great overview of some of the amazing work that HCPF is currently doing in this space. What I want to do is really highlight then now how that work fits in both in the context of and in coordination with other efforts that are being made by other payers in the state, particularly in the commercial market. I want to just briefly note right up top here that Colorado does have a very strong history of care delivery and payment reform innovation, particularly in the area of primary care. So we are very much standing on the shoulders of work that many of you have been engaged in for the past couple of decades really now, and previous initiatives, things like our state innovation or SIM model. So I just want to provide a brief overview of kind of the latest chapter in our ongoing journey in that pathway as a state, kind of where we've been most recently, where we're currently at, and ways that we hope to be engaging you in these efforts. So if you want to go ahead and go to the next slide, just three key pieces of work that I wanted to highlight for you this morning. The first is something called the Colorado Primary Care Payment Reform Collaborative. And this is a multi-stakeholder group that was established by the legislature in 2019. It is facilitated by the Division of Insurance, but it's really designed to be a forum for bringing payers, both public and private, providers and consumers to a common table to develop strategies for increasing investment in primary care for the state of Colorado. One of the key things that group has done to date is to actually set a primary care investment target in the commercial market. But in setting that target, that has gone hand in hand with conversations that as we're increasing investment we want to be doing in primary care, we want to be doing it in a way that's actually driving value into the system, which is something fee-for-service payments just can't do. I would say hand in hand with the conversation about increasing investment through value-based payments is the conversation that those payments, those APMs that are in place or alternative payment models that are in place for that flow of funds in order for us to be actually achieving the true benefits of that type of reimbursement structure in the form of improved health outcomes, decreasing health equity, and improving costs over time. Those models across payers need to be aligned, so multi-payer alignment has become a natural focus of this work. That leads us to the second element you see on this slide, which was a series of stakeholder conversations that the division convened in partnership with HCPF, in partnership with the Department of Personnel and Administration, which administers our state employee health plan, to bring stakeholders together to focus specifically on what could and should statewide aligned alternative payment models for primary care and maternal health look like in the state of Colorado. The recommendations that came coming out of those conversations then led very directly to the third element you see listed on this slide, which was a bill that was passed by the legislature last year. I kind of like to think about it as the newest tool in our toolkit as we're thinking of ways that we're going to be sustainably advancing the delivery of advanced primary care, which includes integrated behavioral health within the state. So House Bill 22-1325 It directs the Division of Insurance to establish aligned parameters for primary care APMs through regulations. That regulation is due to be promulgated at the end of this year. And in developing those parameters, we are currently involved in extensive ongoing stakeholder conversations, which is where you all come in. So if you want to go to the next slide. This unpacks the specifics of the bill a little bit more, but what I really wanted to highlight are those elements that you see on the left-hand side of this slide. So in terms of things that we're thinking about, ways that we can be aligning existing APMs across payers. So with the work that HCPF just presented, with some of the models that are in place with commercial payers, some of the areas of alignment that we think will be the most benefit include risk adjustment, patient attribution, core competencies, or what are those activities that we want providers to be performing to be delivering advanced primary care, and aligned quality measures. So if you are interested in talking about any of those topics, we've got a slew of information on the division's website. You're free to reach out to me. Really quickly, moving on to the last slide here. So far, I've hit on commercial market, I've hit on Medicaid, I have hit on our state employee health plan. Another huge payer in the market is, of course, Medicare. And so just wanted to briefly highlight a new opportunity for Colorado to be engaging with our partners at CMS, CMMI through something called the State Transformation Collaborative. This is really an effort by CMS and CMMI to be engaging at a state and regional level to see how Medicare can be more meaningfully engaging and acting as a participant in models at that level. So a lot of exciting work also occurring in this space as well. So ongoing exciting work, and we'd love to have you be a part of it. Feel free to reach out, and please be sure to visit some of the resources that Trevor highlighted. Thanks.
So thank you very much. Fabulous panel here on value-based payments. We appreciate especially the collaborative partnership. You know, if we can work together as Medicaid and commercial to make it easier for providers, we can get a better outcome, get better results if we make sure we're focused and aligned. And all of us, all Coloradans, all providers really appreciate the collaborative work that you all are doing together. So well done. So thank you very much. Let's go to the next slide, please. And we are going to open it up to questions from the audience. I do want to underscore one of the messages from this last session, and all panelists, you're welcome to turn on your cameras so that we have everybody available to answer questions. But that prescriber tool, one of the interesting things, I'll start with you, Trevor. When we think about value-based payments, you know, we're trying to get outcomes to change. Can you just talk a little bit about the importance of getting 100% of those payments so we make sure providers build habits that help them get to programs, not just pills, right? Get to the front side, all of the neat all the neat tools are being built to get to the core of health and social determinants of health. Can you talk a little bit about how the prescriber tool is, why we're paying that, and what's coming?
Of course. And we recognize that incorporating value-based payments into your workflow, regardless of the program, I'm focusing in though on prescription drugs, is a change in how providers are working. And so we recognize that as the department, one of the most effective things we can do is support you on that transition with the appropriate financial resources so that over the long term, we can work on bending the cost curve and improving patient outcomes in partnership.
Thank you, Trevor. And I just want to recognize the poll that was done. HTP, the Hospital Transformation Program, again, the biggest part of our healthcare system, 35% of people are excited about this on that call. 33% on primary care, 26% on maternity bundle, and really exciting 27% about what we're building around pediatrics, which is just so darn exciting. Let's go to the next question, please. I'm going to hit two in a row, and I'll bring up Lisa and Rachel, please. So can the entire renewal packet, when we're talking about Medicaid and CHIP renewals, be completed online, or does the member have to complete, they have to do this in paper? Do they have to upload, download? Talk just a little bit about that. Rachel, do you want to take that? Lisa, do you want to take that?
Yeah, Lisa, why don't you go, and then I can follow up with some communications around it. So go ahead.
Thank you, Rachel. Thank you for the question. Yes, the entire packet can be completed online. We do encourage members, if they haven't already set up a Peak account, to do so. Not only will they be able to complete their entire packet online, including the newly required signature component. We added that component to the renewal a year ago. It also will enable them to get their notices, any noticing online, which means they will get their notices faster if they're opting into electronic communication through their Peak account. So, Rachel, whatever you want to add to that, please.
Yeah, I think the piece that I would add is we also have access through our Health First Colorado app. So it's multiple ways to meet folks where they are to make sure that they can fill out the forms in the way that's most convenient for them.
Thank you, Rachel and Lisa, for that. Let's go, is our Lauren and Tom on? Lauren, I'll ask this of you. Is the drug importation program going beyond Canada as the source of drugs?
Thanks for that question. So currently, no. We do have a law passed here in Colorado to expand the importation program beyond Canada, should the federal government change federal law. So right now, federal law states that drug importation programs can only source drugs from Canada.
Thank you, Lauren, but we are ready when they are. We passed the bill and done some of the analysis and would be excited for that opportunity. Staying on prescription drugs, Tom, if you are still on, this is from Sammy Diab, Dr. Sammy Diab. Can you comment on the huge amount of rebates generated through group purchasing organizations, the main distributors of specialty physician-administered drugs like McKesson or Cardinal? Do we know how much they're costing the system, and what are the transparency laws governing their operation? How many insights into that?
A little bit. So Sammy, obviously our expertise is Medicaid, so we're very familiar with the rebate structure for Medicaid. But if you look to our RX cost report, we do talk a little bit about rebates on the commercial side and how that's driving overall costs across all health plans. I think, Kim, the rebate pass-through bill probably can help with that. That passed last year. And of course, we're working on spread pricing this year. I think that'll help too. There's a tie into rebates with spread pricing as well. So
yeah, I think Tom, Sammy, there's opportunity there. When I think about what Tom just said, you know, our rebates are about 50% of the dollar in a Medicaid drug, so they're just so much more powerful than the commercial side. The commercial side is about 20% on a brand name drug, and that rebate pass through goes between manufacturers to carriers, and the law says you have to pass all of that through. And Commissioner Conway, as Lila said, is running some analysis and reports to figure out how to share that between employers and consumers when they're at the counter. But I think there's opportunity where this money that's going between manufacturers and McKesson, Cardinal, those middlemen are probably not in that equation. And it's probably a huge call out and an opportunity. So thank you, as always, Dr. Diab, for your knowledge and insights and leadership. All right, now let's jump, Nancy, to you to maybe a couple of hospital questions, if you will. The first one, and is Donna Lynn still on? If Donna, you can add some color to this too. The question is, how much cash on hand do hospitals need for stability? And what are reserves meant to do? I heard them likened to 401ks and rainy day funds, savings accounts for future purchases. And so, Nancy, I'll start this a little bit and then turn it over to you. But reserves are rainy day funds. And you know, when we talk about it as comparing to 401ks, it's not because 401ks are rainy day funds. It's when investments go up and down on reserves that we're making that akin to. People may understand that because they're watching their own 401k, and just like their own 401k might go up and down, and they have a really hard time in 2022 with returns on equities and bonds. We're seeing that with hospitals as well. That's the association with a 401k, but not the 401k or rainy day funds or retirement funds. Nancy, I have some thoughts on this. I'm sure Donna Lynn does. Do you have some thoughts on what's needed for the right number for days on hand, cash on hand?
Yeah, for sure. Thank you, Kim, and thanks to the questioner for this great question. In terms of days cash on hand, we don't know that there's a particular industry standard. Be really interested in Donna's thoughts as well as yours, Kim. I believe we think about 9 months to a year is about the right amount to make sure that you have. And in terms of course, what they're used for is in case there is some kind of unexpected need or some kind of decrease in revenues. The pandemic is a perfect example why some days cash on hand and reserves available for ongoing hospital operations were in need. Kim?
Donna, are you on? So in prior conversations I've had with other hospital CEOs, that 180-day mark is a real indicator they start getting below that 180-day mark, start to wring their hands a little bit. But there are rating organizations like Fitch that would indicate that you might want something higher than that in order to get better rates as you're trying to borrow or issuing bonds and the stability of those. And so there are other reasons when you think about hospital systems, how big they are today versus say 20 years ago, and the expansions that they do or what businesses they're in, what their strategic plan says may indicate that a difference in how much in reserves they want to hold. Nancy, I'm going to stay with you here. The question is there any consensus on appropriate amount of community benefit spending and what should it be spent on? Both. How much and what?
Yeah, absolutely. Thanks, Kim. There is no federal requirement on minimum community benefit spending, and I know that is something that we are particularly interested in as we're working on House Bill 23-1243 along with sponsors and proponents of that bill. The community benefit that nonprofit hospitals it's an obligation that they have in lieu of paying taxes. So these are tax exempt hospitals. They don't pay federal, state, or local taxes. And so in lieu of that, they have an obligation, of course, to provide community benefit. So one of the ways that oftentimes the appropriate amount, so to speak, of community benefit is measured against the value of that tax exemption that they'd otherwise be paying back into the community. So that's one measure. And in terms of, I think the other part of the question is, how you determine what is, appropriate or how we're meeting community needs. And so, as I mentioned during my part of the presentation, that is one opportunity that we see is making sure that there is clear alignment and we can be able to report that and understand between what the community is voicing as the needs for benefits from the hospitals and then where the hospitals are actually spending on. Under the federal requirements, hospitals have to go through a community health needs assessment every 3 years. It's very prescriptive in terms of the community meetings they need to have, and they pull together a lot of information and then ultimately report to the community, produce a community health needs assessment. And they share those with us as part of the existing legislation, and we report on that, as well as under the existing Colorado legislation from 2019. Our hospitals need to hold an annual public community benefit meeting and have an annual community benefit implementation plan that they review with the community there. But certainly we see some opportunity where when hospitals are having to change priorities from what was in those community health needs assessments or in those local community implementation plans, those annual ones, that they are making sure they're getting good community benefit on, or community input, on that community benefit spending plans as needs may change.
Okay, thank you, Nancy. There's one last I want to think our folks from our rural hospital session are in a rural session today that includes all providers, very important, all hospitals. So I want to ask one of these questions. I'll take my best shot at it. So it sounds like the most successful thing in improving rural hospital finances was the COVID stimulus funds. Is some sort of other rural subsidy on the way, or given the lack of bargaining power, and that there are so many patients and spread of overhead costs, is there a way to bring that spread of overhead costs? So I'll say these few things. There's lots of conversations to figure out how can we help our rurals. I think Nancy or Kevin said there was less than an average, or Michelle said less than 3 people in the beds at night inpatient in hospitals. 75% of their money is usually coming from their outpatient and often their rural clinics. So how do we do this better? So some of the things that are on the table, Stephanie shared how do we provide more money so they can build on infrastructure like sharing information. That was the HI called the SHE, the social determinants of health being built. Nancy talked about $60 million over 5 years that helps us, again, invest in their infrastructure so they can get ready for and participate in value-based payments related to that infrastructure. That $60 million over 5 years. Nancy said 30 million's already gone out. That we're also helping them adopt tools which help them be the next generation of provider. So that prescriber tool or e-consults or cost and quality indicators. So when care has to go to the front range, they know where to refer it, where the outcome is better for patients and the cost is more affordable. So there's all sorts of processes in place to help them make a better tomorrow. And we hope the next generation they could be maybe a big ACO, a big physician group that deals with how do they better manage care. And we're working specifically on cost and quality indicators and access points where we can help rurals refer care between each other, which would also close disparities for our rural communities. So lots going on there. Thank you for the question. So with that, I'm going to ask people to turn off their cameras, except for the Lieutenant Governor. We're going to start our closing part. So one, I want to thank all of you for your participation, invite you to look at some of these resources, which is the reports that we talked today, the tools that we talked today, the presentation that we talked today. I want to underscore how important it is to participate in some of this end of the public health emergency in the poll that we did. Thank you so much. 25% of you said you were going to join our April 26th webinar on how everybody can participate in helping the end of this public health emergency to keep Coloradans covered. 17% of you said you were going to conduct outreaches to raise awareness. 36% then you were going to remind your Medicaid members, support individuals that you deal with. 18% said provide coverage through Connect for Health. So really, really spectacular there. So with that, LG, I'll turn it over to you for closing.
Thank you, Kim, for all your work too. And I want to thank all the attendees and our wonderful speakers for joining us today. And thank you all for being here and for being champions of access to affordable health care. You know, from lowering insurance costs to targeting burdensome prescription drug costs and working to transform our behavioral health system, we've made significant strides towards ensuring that all of our neighbors have access to high quality, affordable, equitable health care. As we probably heard today, here in Colorado, nearly 10% of Coloradoans were unable to fill a prescription because of cost in 2021. And Colorado still ranks among the top 10 for hospital price and profit, meaning people in our state pay more than others around the country for hospital care. And we believe that no one should have to choose between medical care and making ends meet. But unfortunately, that's still a reality for too many Coloradoans. So hospital care and prescription medications aren't elective treatments. In fact, they're often critical to daily wellness and your ability to survive. So we've done really good work to begin to bend the cost curve. The bipartisan reinsurance program is expected to save Coloradoans nearly $1 billion by the end of this year. Colorado Option is driving down premiums, saving people money on healthcare coverage. The Prescription Drug Affordability Review Board, as we heard, is beginning its work to lower prescription drug costs. We've made great progress addressing surprise billing, and we're creating a strong, stable healthcare workforce. But as you all know, we have more work to do, which is why our administration announced a package of legislation to continue saving people money and increase transparency within the healthcare system. So the package seeks to lower the cost of prescription drugs by continuing to set the groundwork to import lower cost prescription drugs from Canada, to strengthen the Prescription Drug Affordability Board, which we heard about, and increase its impact, and look to hold middlemen, pharmacy benefit managers, and insurance carriers more accountable. The package also seeks to continue to lower the cost of insurance premiums by strengthening the Colorado Option to make it easier for the Division of Insurance to hold carriers accountable for rate reductions, streamline the public hearing process, and help Coloradoans more easily find low-cost plans that work for them and their families. And finally, on hospital accountability and transparency, the package seeks to ensure tax-exempt hospitals engage with the community they serve to identify and invest appropriately in critical, locally identified needs, as well as seeks to expand hospital financial transparency reporting. So once again, I'd like to thank our legislative partners, our provider community, of which my daughter is a member, advocates, and Coloradoans across the state who have shared their stories that have informed this really important package. So please stay engaged with us as we continue to work towards impactful reform. We appreciate your partnership and couldn't do this without all of you. So I'll pass it back to Executive Director Bimsteffer to share some of her final remarks.
Thank you, Lieutenant Governor. Appreciate you every day. To the 1,000 registrants, we couldn't make a better tomorrow without you. To the 21 panelists, we sure do Appreciate your expertise in sharing and your leadership and helping us bring that better tomorrow. Thank you all. Have a wonderful week.